Yes, we've had some of those numbers, and it's very early in the program, so we have seen some trends change, and one of those is ER visits. And we can look at that and give some information on that, and the readmission numbers,
And I guess the other
and on the episodes of care.
I think that I visited with Bob some about, and I think it's important for the task force to understand, you are a managed care program, correct?
Yes, sir.
So you're a managed care program that is implementing episodes of care, payment improvement, PMCH, through basically without regulation or law change, just as part of the way you manage the care.
Yes, sir. We are a managed care type program. We use a lot of those tools, but this is another tool that we have to help bend our trend, keep our costs down.
Okay. All right. Do we have any questions from anyone else, members of the task force? Yep. Push your button there. There you go.
I don't know. Okay. I have just one question. Your program is self-insured, right?
Yes, sir.
Okay, so you don't have an insurance company that you have to go to the regulations, you can develop your own.
Yes, sir. Well, we have our claims payer, and we do a lot of what they do.
And you never reassure them?
No, sir.
No, you're just straight self.
We're straight self-funded.
That's all.
Okay, Bob, appreciate you coming down and your experience. Again, I think some valuable points about what the impact of the payment improvement initiative is. Okay, now we're going to have our consultants who spend a lot of time looking at this program give us their assessment of it. So, Don, why don't you come down with your team there, introduce yourselves, and you're recognized to give us your thoughts on the success and cost and whatever of this program.
Thank you, Mr. Chair. I'm going to try to go as quickly as possible. I know it's been a long day for everyone. I want to first introduce Stephen Fong, who we met yesterday. Stephen is one of our chief consultants who's really focused on Medicaid policy and analysis and financial, and he was actually a healthcare policy advisor for Governor Perry for a number of years, including advisor to the Texas legislature on healthcare policy. Bob Chin is I'll let him give his background, many years of experience in healthcare policy, private insurance, all kinds of DRG methodology as well. I want to say real briefly, as Stephen gets ready, just listening today to some of the discussion, we've done a lot of work with the department. I want to thank them for their help, continued help. I also want to point out Dr. Golden was here earlier, who's been really helpful on the high-cost utilizer issues. We've been internalizing and looking at some of the numbers ourselves, and I want to just urge to the community again, we heard a lot about PCMH, we've heard a lot about episodes you're going to hear from our side in terms of what we're evaluating for you all, but I really want to keep, you may just think I'm a broken record, but I want to keep focusing your attention on the high-cost areas of this program. PCMH is not even involved in the high-cost area. Episodes is not even involved in the high-cost areas.
So why is that?
There's a history center Sanders asked me to review yesterday. We're going to do that and bring that back to the task force.
Okay.
And Senator Ingram and I had discussions about behavioral health. We talked about the children in the budget, the RSPMI section of the budget, serious persistent mental illness. We talked to you about some of the long-term care issues. We're going to next meeting, I know it's going to be discussion, but I just don't want you to, we can have all the discussion here and how great episodes are and everything else, but you've got to start focusing, I think, on also that real high-cost penetrated area. Okay? And this is Steve Palmer, and I'll let him take over.
Great. Thanks very much. Chairman, members, my name is Stephen Palmer. I'm a senior consultant with the student group. And I'll be going through some slides on the payment reform payment improvement initiatives. The first chunk of slides in my presentation have largely been covered by other presenters, so I'll move through those very quickly. I will call your attention to one, there's a mistake on one of the slides, on slide 7. Several of the fields in the second column were transposed, and they've been corrected in the slide and will be corrected in the report that's released. Now, just mention that when I get there. So we've already talked about the payment improvement initiatives, what they are, how they're structured. The patient-centered medical home, first 4 slides. I'm not going to get into that, but happy to answer any questions if you want me to dig into those. The rest of the presentation primarily focuses on the episodes of care. These next 3 slides are are the same as the McKinsey slides that DHS showed about the actual experience of the individual episodes of care. I'll be using some of the data from this in the subsequent analysis that I'll be discussing, so I do want to call your attention to the final column, the estimated direct savings to date. And that was discussed in the earlier presentation. This slide is just the qualitative results that have been seen. Again, this is the same data that was in, the same information that was in the McKinsey slide that DHS presented. And then these are the episodes that have yet to be rolled out, or that have been rolled out, but for which not enough time has passed to have enough data post-rollout to compare and to estimate potential direct savings. This slide is the rollout dates. The important thing here is just that they've been rolled out in batches that align with, generally align with state fiscal quarters. The most recent ones have not yet been out for a full year, including the run out necessary for the claims resolution. So with slide 10, I'm going to get into our additional original analysis. So I'll talk through this in a little bit more detail. Just first to set some numbers in your head about the scale of the episodes program. Across all the episodes that have been rolled out so far, they cover approximately $180 million worth of total spend. And then the total annual spend on other episodes that are related to those same principal accountable providers is almost $1 billion. So when we look at those individual episode level direct savings estimates and apply the actual spend on the individual episodes to those estimates, we get a range of 6.7 to 11.7 million in annual savings for those episodes where we already have a year of post-rollout data. That is the first 7 episodes. If we
Is that each episode or total?
That's total. Total of the first 7, yes. And then if we make some assumptions about the potential cost savings associated with the remaining 7, by looking at the first 7, and apply those to the actual dollar amounts of the episode costs in aggregate, we get a range of between 6.9 million and 28.2 million in annual direct cost savings. And that's with all 14 of the episodes that have been rolled out so far. Now, there are a lot of assumptions baked into that. That assumes that the episodes for which we do not yet have a full year of post-rollout data perform like the episodes that we do have data for.
In your work with DHS, do they agree with these numbers with regard to low and high area spends and savings?
The numbers, we haven't discussed the methodology of underlying the assumptions for the 14 episodes, but the numbers for the first 7 episodes, that's a simple multiplication from the ranges that they reported and the total spend on individual episode basis that they reported.
So you and everyone else is in agreement that it is somewhere between 6.7 and 11.7 for the first 7, that you've got enough experience to make a decision?
I wouldn't want to say like everyone.
Even DHS?
We have not discussed this depth with DHS.
Okay. Representative Farr, you have a question?
What methodology are they getting these numbers from? How are they getting?
On the on the estimated direct savings today. So they have looked at the changes in the experience associated with those particular episodes, and that would be things like on this slide, looking at the drop in antibiotic prescribing rates, drop in C-section rates, change in average episode costs, and then on an individual episode basis, made some estimates about what that actual dollar amount is corresponding to those.
Does the Stevens group agree with their methodology?
Their methodology appears to be reasonable. Now, one other thing that I'll get to more, though, is that what we are observing is correlations. These are changes in the patterns of service delivery and the rollout of the implementation, or after the rollout of the episodes, compares the pattern of costs and care before the rollout. There have been a number of things happening at the same time that could potentially be contributing to that, including PCMH and the triad option, and the macroeconomic trends and other outside factors.
I guess the word, I suppose we would ask, the economic effect of this, healthcare all over the United States, paying its way down. Does that contribute to that? Or?
It's not, at this time, we have not been able to disentangle those effects. And given how many different things happened at the same time, we're having at the same time, and how little, how few data points we have at this point, I don't think that we will be able to fully disentangle those effects.
You have a time frame when that would happen? Good.
The challenge there really is that this program, particularly the episodes program, is so new that we've got essentially one data point post implementation of most of the episodes, and it's really difficult to generalize from that in a robust way.
I think I've heard a lot of that. Basically, educated guesses.
Well, they are educated guesses, and so, well, let me say it this way. For the estimated direct savings, those are measures. But one of the assumptions is that those direct savings are a result of the episodes program. And it could be a result of multiple different programs, multiple different things happening.
So you're guessing on the reason why it's like.
Yes.
Senator Sanders, you have a question?
Yeah, one thing, Stephen, I appreciate the work and certainly love your former boss very much, and appreciate some of the work you did in Texas on the governor's 1115 waiver that didn't get approved for premiums. I think one of the first large-scale premium assistance programs to be proposed. As you, and I think what you're doing is you're kind of sort of getting more to the point. As you guys begin to look at this, I would encourage you to sit down with Bob Alexander, who you just heard from, to begin to take into consideration some of the savings there. I would also encourage you to sit down with Blue Cross and look at the savings there. I would also encourage you to sit down with our ERISA friends. Walmart is probably our biggest partner in payment reform. Look at what they have estimated that it has saved. The people there, the Vice President of Global Limits at Sally Wilborn, would probably be able to point you in the right direction as far as what it has meant to them as going. This is, again, it would be one thing, I think, if we were just talking about payment reform for Medicaid, but in Arkansas, what we've achieved is sort of system-wide buy-in, not just from the fully insured market, but also our ERISA partners. That would, I think, would help out. I like your analysis. I like what you're doing. I think we just need to expand it a little bit further outside.
And we have done that qualitatively. We've had conversations with Bob and the Walmart record for benefits, but we haven't tried to quantify that yet. That's good.
Jake, we've got another question, Senator Urban.
On page 10, could you clarify that the 995 million figure, the total annual spend on all national?
Sure. So if we go back to the descriptions of the episodes, we have here in the second column the direct episode spend. That is the actual amount that was paid on claims for that type of episode per row. And then if we look at the principal accountable provider, like in the first case, it's a primary care physician, and then look at all other things that could potentially be packaged as episodes and the cost of all those other services that could potentially be packaged as episodes, we get to that number, which I did not include in those tables, but I did include some later. That's all the services for the principal accountable providers that are currently in the episodes program that could potentially be bundled or packaged as episodes. The reason for including that is because there is one idea around the episodes initiative that you might have a sort of additional echo effect of the episodes. If, for instance, providers are changing their behavior for the services that are within the episodes, they may similarly change that behavior for services that are outside of that episode as well, changing referral patterns, changing prescribing patterns, etc. And so that's indicated just as a sort of aside that if you were to roll out the episodes program to its full potential, that would be
design, implementation,
No, I'm sorry, those are direct service costs.
direct service costs. And then the 6.9 million, the projection is after the spend, that would be the,
And that's just for the episodes that have currently been rolled out, the 14 episodes that have currently been rolled out, not the episodes that will be associated with that 995.
and the 179.3, is that, where does that number come from?
That's the total spend on all the episodes, estimated annual spend on all the episodes that have currently been rolled out.
Is that from contracts?
It is if we look at,
I see, it's on page 11, we haven't got it yet. Sorry,
Okay.
thank you.
Sure. Okay. Picking up at the bottom of page 10, so we have then, looking at just the seven episodes that have already been fully rolled out, again, analyzed potential direct cost saving range of between 6.7 and 11.7 million. For all 14 that have been rolled out, that includes assumptions about those that have not yet been analyzed because there hasn't been enough time since their initial rollout. We have potential direct savings of between 6.9 and 28.2 million annual. Going on to slide 11, this gets into the costs of design, development, and implementation of the episodes program. There were three major contracts that supported design, development, and implementation of the episodes program. McKinsey, General Dynamics, Information Technology, and Hewlett Packard. They totaled over the 4 years of design, development, and implementation, just over $60 million. Looking at the individual episode costs, there were 14 episodes developed over that course of that time. And then just, again, same amount yields per episode cost of about 4.5 million for design, development, and implementation. And that compares then to the potential cost range of the individual estimates of between 1 and 1.7 million per year.
Okay, so can you, when you say the estimated annual savings, is that including the ongoing operational costs that are factored into that?
No, we don't yet have good estimates of the ongoing operational costs. That's not something we try.
I guess what I'm saying is, if you look at it from a perspective of it costs us $4.5 million to design, and it would say 1.5, so you're saying you get a 3-year payback minus whatever the cost, additional operational costs are.
That's right.
We don't know what that number is.
We have not tried to identify that number yet.
I mean, because obviously a 3-year payback is not awful for something, but what I would like to know is it really a payback? That's why we need to know what that
And
operating.
we'll try to identify that. So far, a lot of the costs associated with design, development, and implementation have also had embedded within them the early year operations costs. We haven't tried to extract that yet, and we haven't yet reached a steady state with the program itself.
Okay, Senator Sanders?
To your point, Chair, we actually have legislation and contracts in place in Arkansas where we allow for 20-year paybacks on state projects. So, in the private sector, a 3-year payback is pretty good. I've been to your plant up there at Gravit, and I think you run a pretty efficient operation up there. But you buy things you can 3-year payback on.
Right on the operation.
Yeah. I would encourage others to go visit Senator Henry's manufacturing facility. It's an experience.
Go ahead, sorry. Oh, wait, we got another question.
Are you projecting out on the rest of the episodes of care also, or estimating the cost of those out also?
No, this is just based on, and I'll address some sort of caveats and assumptions about that. This is purely based on the experience so far with the development of the episodes so far. And there may be situations where there are efficiencies in the development of future episodes because the groundwork is already laid and they already don't have to have any or as many starts and stops.
So then I guess my question is, the next episode may not cost 1.5, it may cost 5.5, it may cost 2.
And it's also not necessarily the case that every one of the episodes that has happened so far costs exactly 4.5. That's an average across the entire design, development, and implementation so far.
If I could just add, Mr. Chair, the McKinsey discussion later that Martha has each of the episodes and how much each cost is going forward under the McKinsey contract, so I think that might help when you see that.
Then, picking up on slide 12, I wanted to address several of the different, or mention several of the different mechanisms by which episodes might operate, by which they might change patterns of care and costs. The first is episode cost reduction. That's the most direct and the one that has been discussed most. That's where just the individual, or the average cost of episodes goes down once the episode is initiated. The second second and third are different types of episode avoidance. There's at least one type of appropriate episode avoidance, and that is where individuals who might be not good candidates for a particular procedure, for instance, are not given that procedure due to awareness of the provider that this person might be a high-cost outlier. We could see some of that also around the individual episode cost reduction. One example there is that they have seen a decrease in the number of the total joint replacements. Well, that could be the case that certain patients who are not good candidates for that are not getting that procedure. And then there's also potential inappropriate episode avoidance, where potentially patients are getting additional diagnoses or changes to diagnoses in order to avoid the episodes. There's some evidence from that from the ADHD episode, but it's small compared to the overall decrease in cost in that episode. And then finally, there's service substitution. And this is one that really has not been analyzed much and will require quite a lot more years of data to analyze fully. And that's just the possibility that some patients are receiving other services that are not part of episodes in lieu of episodes. And again, that's not necessarily a bad thing, but it's just something that needs to be considered as a possible thing.
Okay, Senator Cooper, you have a question?
Yes, thank you, Mr. Chair. Those appropriate episodes would be a provider maybe talking a patient out of something?
Yeah, one example that's been discussed is, say, an obese patient that might need a hip replacement. Clinically, it would be more appropriate for that patient to lose weight rather than have a hip replacement immediately, because for obese patients, the joint replacement tends to come with lots of complications.
Or a joint, or a potential joint replacement for somebody that had heart problems?
It could be any number of comorbidities.
Thank you, Mr. Chair.
Okay. Going on to slide 13, I mentioned that there are a number of different factors that can confound the analysis of the impact of this program. The one that I mentioned most specifically is that there were a number of different programs rolled out at the same time, episodes, PCMH, and private option, all of which could have potential impacts on the pattern of care. And so it's difficult to disentangle that. So again, that's just reiterate the numbers that are being reported as potential direct cost savings are identified as changes in the pattern of care after the rollout of these programs. And it's very difficult to really pin down causality. The second I want to mention, and this has been was alluded to earlier, is that there have been national macroeconomic factors that have been putting downward pressure on health expenditure growth over the last few years across the board. That's affected both public and private payers. We've largely seen a flattening of healthcare cost growth over the last several years. There's some sense that may be starting to tick up again. That was largely attributed to the sort of after effects of the recession. And I also wanted to mention some other effects that might actually increase the impact of the episodes program over time. The first is just the basic learning curve. We know that one of the major mechanisms by which providers get information about the episodes and about where they stand is the reports that get routed back to them. As providers get more accustomed to using those reports, they may get more effective that intervention might become more effective at actually lowering the cost of the episodes. In addition, I mentioned that there's this possibility of induced effects on other services due to participation in the episodes program. That could be changes in referral patterns that are driven initially by information that comes through the episodes program, but lead to that same referral pattern being used for other procedures as well, or changes in prescribing behaviors that might be used for other conditions as well. So that, though, is just to reiterate the point that 1 year of data on a program like this does not necessarily give us a very strong indication of its full potential. And with that, if y'all don't have any other questions, I'm going to hand it over to Bob Chen for some additional commentary.
Before we start, Senator, any other questions?
The question on page 13, so, I mean, a lot of times I hear, well, we saved Medicaid shortfall because of this program, or we saved it because of high adoption. So there's no certainty to be able to say that. I mean, from what you've outlined here, other factors that could play a part, it's difficult to say in fact. Is that correct?
I think that's right. There are a number of these programs rolled out around the same time, and particularly the actual cost savings estimates come from around the same time that those programs were all rolling out. So it's difficult to disentangle those.
And then finally, on page 12, on the episode avoidance, you're talking about the high cost outliers, and your example you gave, liability plays a big part of that. It's very, a lot of surgeons just aren't going to take a patient with a high-risk patient into surgery because of severe complications, fatality. Does that play into it? And do you think that would play into that also, and also their avoidance of trying to make sure that they don't have too many of those complicated patients?
It could.
Go ahead, you're right.
I'd like to follow on that line of discussion and suggest that, in my experience in many of these cases, it's almost impossible to actually have a definitive causal relationship between some program that you're doing, because it's unlikely that you're only going to do one. You're going to be doing a bunch of different things that can actually have some collective effect. And so to ascribe the value or credit to one program will always be very difficult from a quantitative standpoint. Instead, I would suggest that your organization consider what the model is delivering. Is it delivering the quality that you expected? Is it delivering on the general goals and objectives of what it is that you're looking for? Is it going to, in total, be able to assist in the economic challenges that you face and be able to meet that gap? Because if they serve those needs, and if we look at things like the operating costs, because I think if you look at it, the developmental cost is really a minor point, almost a footnote, compared to how much it costs to operate, how much is it being. But to the extent that we can measure those, I would suggest that that's actually a more important measurement, as the one that we're working on right now. And so, if you find that an episode of care is working for a particular area, the question then is, can we do better? If this is better than we have, and it may in fact help in the grander cause, it may be something that you want to maintain. But if it isn't, then you have to look at, well, we're not getting our money's worth, or we're not generating the results we're looking for. And that's a different analysis that they do with a different action. So I have a summary of what Stephen had discussed. And I think our team felt that overall the sort of care model was really very thoughtfully designed and constructed. I think that it's very deserving of the kind of attention that's getting from other parts of the country. So we're pleased to see that it was designed with that kind of care and consideration. It has characteristics that focus on both medical cost as well as quality, and has the upside, downside, skin in the game characteristics that are generally good for these kinds of programs, where there's stakeholders that are going on conversations that we've had with DHS, as well as I've had some conversation with Blue Cross of Arkansas. There have been measurable positive results, albeit modest, of either bending or flattening the cost curve. Still early, not sure about sustainability, certainly not clear about the causality of it, but it's certainly not extreme from the standpoint of generating tremendous obvious savings, nor is it an issue where one would consider it a failure. So more evidence will need to be gathered for that. I think that it would be really important for situations where one of the private option payers has generated good experience for that information to be shared with DHS and for some collaboration whereby all parties can learn from that experience and to look at the episode of care findings in a way that will allow everyone to benefit as much as possible from it. I'll take one example which I had heard of regarding, I believe it was the orthopedic surgery episode, where it was observed that the primary accountable providers were actually making decisions that had economic consequence in mind. That is to say, they were acting as fiduciary purchasing agents, taking into account quality as well. And I believe that is what the objective of EPSO is all about. And so we were speaking earlier regarding the expansion of the EPSO care model. And I would suggest that if you get the sense from the evidence that orthopedic surgeons get it, that they understand this program, that they're making it successful, that they're generating results that you're looking for, maybe that's really the area where you should be spending your time and effort in expanding. And it will likely cost as much, if not less, than bringing on brand new episodes, introducing new specialists and so forth in other areas. And so that's really just a pragmatic approach to the sign of something working and really taking advantage of it, because you've seen that may be an area that's worth investing. So just a thought to share.
Okay, we got a question, and we'll let you press on. Surgeon General, let's up here.
Thanks, Mr. Chair. Just a quick question for you guys. I know you have worked in a variety of states and talked to a lot of leaders in other venues. So whenever I look at this information about the cost curve and what's happening nationally, everyone is unified on one point, and that's that we can't keep doing what we're doing. So there are all these theories about how to do that. There's the managed care perspective, there's the episodes of care, bundle payments, that sort of thing. There's other theories out there. Looking at this program, would you say that based on what's available nationally, are we heading in the right direction with this, or is it too soon to tell? Or would you say that comparing it to the other theoretical models or real models that you've seen, we're heading in the wrong direction? Or do you kind of understand what I'm saying? Are we generally going in the right direction as far as you can tell, or do we not have enough data?
Yeah, I can address that. Our team did address that issue. We felt as a group that this state is embarking upon something that's very complex, nationally recognized. At the same time, while there's already well-proven methodologies out there that other states are using to control this cost. And that's kind of in a nutshell. I'm not saying it's a bad thing, it's just that it's a lot of time and effort, it's a lot of design work, it's a lot of new, versus innovative. I want to give them a lot of credit, I really want to. Versus what surrounding states and other states have been doing for a number of years that you're not doing, and addressing some of the high-cost areas. And that's basically what we came down to as a group.
May I ask a follow-up question?
Sure.
So you might be getting to this later in your presentation today or even in later days, but if other states are doing this and controlling the costs, is that simply managed care, or are there other models that we're not we haven't discussed. Because what I hear when I talk to people is either continue what we're doing with maybe an overall rate cut or to the fee-for-service model, or it's doing something like what we're doing here in Arkansas, or it's managed care. Are we missing something, or are those the three big buckets?
I think it's not as easy as that, but managed care is one of them. So the managed care model is different. There's a capitated model for this. There's a managed fee-for-service model used in some states where the assessments are unified, uniform, standardized, and where there's still a fee-for-service program, but you're paying like let's say $24 a month, whatever it is. I think West Virginia uses the model to a provider that is, again, independent. The front door is independent, and they're doing best they can to make sure that the services are given to those that are in need, right place, right time, right service. That is not happening here. And I think you can do a bunch of models to get to that point. And I think the DHS recognizes that, so I want to make sure that we know that, especially with regard to those complex ideas, as well as what we tried to show you yesterday, and why we thought it was so important. And Senator Hendricks started this discussion by requesting the top 100 utilizers. We wanted to show you the top 1,000. And when you start looking at that top 1,000, you start seeing some of the behavioral health costs, and you start seeing some of the hospital costs, and other things. You need to have a complex care coordination management approach. Other states have already done that. So this is kind of the answer to the question. When you say managed care, I want to be careful. It's not just one model. It's a lot of different thoughts and ideas.
Thanks, John. It's very helpful. Thanks, Mr. Chairman.
I want to touch on what John had suggested, which is that we're really looking at a very small subset of the case types, which represent a very small subset, a micro fraction in some ways, of the entire spend and the budget challenge that you may be facing. And so the approach that we would suggest is that regardless of whether you're looking at a fraction or something bigger in terms of an overall approach, you have to evaluate an all-in approach to what it is that you can do and what kind of outcome you can generate. And so we approach that same thing even when we're looking at episodes. And our chief concern is, number one, can we establish that this is a clear winner from the standpoint of delivering the objectives that you want, and it's actually yielding some economic gain, for example, savings. And whether or not this is scalable and be able to reach out, if it were a winner, to the point where it would have meaningful impact. So that's really the biggest challenge here, while we're actually trying to establish what the outcome actually is of this program. John had mentioned that there are other approaches that can be complementary, or in some cases a stopgap, if you will, for a situation where episodes may in fact be the long-term solution that your organization may want to adopt. And this is not innovative, by the way. This is everywhere. It covers all Medicare, DRG payment model. It covers most of all commercial products, inpatient and many outpatient procedures. 75%, the last bastion of fee-for-service, do more, earn more model is probably Medicaid. And even there, it's only taken about 33 years, but 75% heading toward 80% of Medicaid plans are heading to a DRG model. And we're only talking about the model. We're not talking about who's going to get cut, who's going to make more, who's going to be penalized, and so forth. The reason why we are very much a proponent of the DRG payment model is because it is so universally accepted. It has had over 3 decades of evolution. You will always be able to find argument about this doesn't work here, or these particular services won't fit into this particular relationship that we have in this area of the state and so forth. But I suppose my suggestion is that if you have a big problem you probably at least want to consider a model that has, by and large, been what is considered most practiced, if not best practice, across the country. And so our suggestion is that we do an evaluation of the DRG payment model and have an economic exercise of measurement, metering, to see what it is that that could yield. And so we're proposing that we do that kind of simulation. What would happen if the fee-for-service system were to adopt a DRG payment model? And at what payment levels would you be able to save what? And what kind of disruption would that cause? What percentage of providers, depending on where they were before and where they are going forward? Typically, these models are done by essentially picking a line that you're going to deal with your disruption layer, which means that everybody who used to earn a lot more than that would feel rich, but that the vast majority of your providers would in fact not really feel the economic weight of it. And as I mentioned earlier, they're already living with the system today. Therefore, it's at least worth a second look.
Okay, Dr. Bledsoe has a question, and just for y'all, John, your team, I'm not going to be done with this here in the next 5 or 10 minutes, so we can press on to the next item. I think we've got it just about worked out. But go ahead, Dr. Bledsoe.
Just one quick question for those of us who aren't familiar with all the terms. DRG, could you please define that for the
That's the diagnostic related group. I'm sorry. It's been around for a while, but I shouldn't presume the acronyms are.
Okay, Senator Irvin, you have a question?
Yeah, quick question. Just so I think, one of the things that I'm frustrated a little bit with is, Bo Ross from the Hospital Association said that they lose 83 million on Medicaid patients annually. And you said that this is only 30% of the total Medicaid budget, and there was a report 4 years ago or so that looked at the high growth areas of Medicaid, and they weren't, it was in the, I think it was in the top 10, but the top 5 weren't even this. So I guess my question is, and I think this goes back to the question about the history of why that is, why we weren't addressing high costs or high rises in different areas with this program, but also what led to this? Was this because there was a state innovation grant out there that we saw the opportunity to take advantage of, and then we decided to build this instead of going with something that's already been in place in other states? I'm trying to understand the reason behind doing what we're doing, because that's my main concern is spending all this time, energy, effort on this. Is it going to yield us what we actually have to find in savings and Medicaid? That's my concern, because there's a lot of negligence, in my opinion, in a lot of areas, other areas which Don already pointed out, that are just simple fixes that could yield lots more millions of dollars, that are just simple turn on the light switch kind of fixes on different areas of Medicaid and management. So that's what I'm trying to understand.
And that's a very reasonable line of inquiry. That's something that we'll be looking to provide more information about in this. That's really.
Senator Sanders.
She's right. I think what's important is providing the sort of the framework for sort of the legal background that exists in Arkansas with regard to the consent decrees. Part of the history that Steve is going to pull together, hopefully in a nice little narrative form, in terms of looking at types of reforms that have been pursued. There was a time in the aughts when I was a columnist covering the legislature where DHS actually tried to do managed care, and it was shut down. So there have been attempts at other things in the past, but I think getting a true sense of other reforms that have been tried over the years and the kickback from the legislature in many instances, and some of the things that we've done in both the regulatory process, the special language process, you name it, all the things that we've tried to do to trip up innovative efforts. I think fully understanding that would be good. We are a gentleman, I think, I'll ask you the question, is Arkansas one of the more unique Medicaid programs that you've been exposed to in all your years in terms of our construction and what we do and what we don't do?
They're all unique, and
No, okay. Most unique that you've ever seen.
Plenty
He's
unique.
an attorney, I would remind you, former prosecutor.
Unique enough. Yes.
There's some aspects.
Before we leave this, I just have one, I want to get straight in my head the savings and the cost. As you said, on an average, 4.5 million instead of 11.5 million a month in savings, or $1.5 million a year in savings. When you say $1.5 million, is that entirely state dollars? Is that takes into account the match, or is that program dollars?
That's program dollars.
Okay, and the same thing is true of the $4.5 million episode. That's total dollars, so it's 25% of that is owned by the state, 75% by the feds, and on the spend, I guess it's a 70-30 match. Is that correct?
On the episode design, development, and implementation, it's a little more complicated because there was some grant involved.
All right.
And then not all of the spend falls under the normal health services match rate. But once you take it all into account, you actually end up with something like 70-30 on the balance of pay under total.
Okay. Again, I think, to wrap this thing up, and I know you'll have this in your final report, I think what would help us, again, as Senator Sanders said, 3 year payback isn't bad, assuming that we really are utilizing those type of savings. I think we have to make sure we're considering the operational ongoing costs that might be incurred. And then also what the impact of the state budget is at the end of the day when we consider the match rates and those factored in. Christine Ferrari, you have a question? That's the last on my list, and then we're moving on.
Yes, but is the DRG model being done in the other state? I mean, for Medicaid, I'm sorry, not Medicare.
Medicaid, it's being done in about 75% of the other states, and there's probably 1 or 2 states that are hopping on every year or so.
What's the result? Any result?
Well,
Savings on the Medicaid system?
clearly, everyone's jumped on DRGs and stayed there because they have found no better solution than that from the standpoint of practical, scalable, operable inpatient services management in terms of cost, as well as certain outpatient procedures.
So it is a model like Medicare?
That's right.
Even outpatient?
Yes, sir.
Thank you.
Okay, John, do you have anything you or any of your group would like to add before we wrap this up? Again, I don't-
My last slide was about all the things that we talked about earlier, all the other areas that we need to look at, that savings need to be achieved.
Okay. Okay, yeah, and again, I know this also folds into the discussion that we've had and was later on the agenda about procurement and contract, because obviously that's a big part of the development cost, making sure that we are procuring with the most affordable method possible. Maybe you guys can give us some guidance on that at some point. All right, ladies and gentlemen, we're going to move on to the next item on the agenda, item D. Before DHS comes down, I've got a guest that I'd like to have come just quickly share her experience because it has to do with eligibility and verification. This is also kind of unique. This person came to my office. Her name is Cindy Akers. She's a former legislator from the state of Colorado, but an Arkansas native. And she came by with a tale to tell me because as we talk about eligibility verification, we tend to focus on how do we make sure that people aren't ineligible, aren't receiving benefits. But what sometimes we fail to realize is what about people who are eligible but are not receiving the benefits? And I think the story that she might relate to me, to you all, shows the importance of making sure that we get control of this system and this program. So, Cindy, if you would just identify yourself, tell a little bit about your background, and then share with us your experience, and then we're going to, again, I know we've got a lot of stuff on our plate, but I think this is so relevant to what we're talking about, the eligibility verification.
I'm Cindy Avery. I'm from Bentonville. I have lived in Denver for 30 years and just moved back here to retire and finish my career. My concerns illustrate some of the issues associated with the end user and with the process with procedural. When I was at the legislature in Colorado, after chairing the board of the largest neuroscience center in the Rocky Mountain region, and sitting on the boards of hospitals, I also was the vice chair of health and the chair of the audit committee. Did a lot of procedural audits and looking at Medicaid-related issues, sat on many commissions and state and national boards and did projects for the Department of Health and for the U.S. Department of Human Services. So in light of that, just recently, my experience was that I had lost my job. I'm under 65. I have no income. I'm widowed, so I'm meeting the income eligibility qualification and went through the Access website to apply. for insurance. They referred me to Medicaid, we filled out an application. Unfortunately, as the time clicks, you fall out of compliance of the 60-day requirement for changes in circumstances when you need to apply for individual insurance policies. So in April, we filled out an application. In May 2nd, I received a letter of denial from the Department of Human Services citing that I was ineligible because I was incarcerated. Well, it's obvious that I'm not in jail and I've never been arrested. So I was concerned immediately that maybe someone had my ID or there was just a mistake that we could easily resolve. I spent hours and hours and hours on the phone trying to get through someone at Human Services that could help me. And when I finally did, I was told that they could not address the problem, that I had to go back through Arkansas Access, even though their name's on the letterhead. And I thought it would be an easy situation. They could check the data and just let me know if we had a serious problem or it was just a typographical error. I spent a total of 51 hours on the phone with Access Arkansas trying to get through to someone who could help me resolve this problem. And about 3 weeks ago, after visiting Senator Hendricks, I finally did get a hold of someone in Arkansas Access, and I was told that he could not help me, that I had hit the wrong option and needed to go through number 3. Fortunately, I received a call back last Friday from the Department of Human Services explaining to me that they were willing to help me solve the problem. They put me on hold, came back quickly, and said that there was just another Social Security number similar to mine, not the same name, but it just got typed in wrong. And that if I would start over and go to my local DHS office, they would try to resolve it. In the meantime, I had applied for a private policy and was told that since I was no longer in that time frame for eligibility to transfer to an individual policy, the only way they could do it is if the state made a mistake. So I had to prove that a state agency made a mistake, and at that time could not get a hold of anyone to verify that, but I sent a copy of the letter to Blue Cross Blue Shield, and they're willing to issue a policy now. So I've been out of insurance for 5 months. Had I had a catastrophic event or some type of health problem, it would have been a serious issue. I served as executive director for Havenwood last year and part of this year that housed single-parent families, 90% of which were on public assistance. I cannot tell you how many times I had to intervene to help these families get benefits that either had been terminated erroneously or to finish supplying information that continually seemed to disappear or have problems in the application process. So there are several procedural issues that I hope this body can address in terms of both eligibility determination and the process of application and verifying eligibility. So I thank you very much, Mr. Chairman, and this committee for hearing my story.
Ma'am, I thank you for sharing your story, and I'm so sorry to hear it. And you talked about your personal story, you talked about people at Havenwood. I know I get lots and lots of calls. And so, sitting up here listening to, the testimony hour after hour, week after week, it seems like there are 2 groups of people. The needy and deserving, who no matter what they do, cannot get coverage, no matter what. And then the bums who are loaded to the gills on the system, and somehow we can't get them off. So I'm trying to sort out, could that possibly be the case, or are we not really able to get a clear sense of what's really going on? Because it just seems so hard for me to believe that there's all these folks that are doing the right things and cannot get on the system, and yet we have, from the newspaper accounts, tens of thousands of people who don't belong on there or on there. Is it just that we're always getting the wrong person in the wrong place, or what do you think is going on there?
Well, just as a business development consultant looking at cost-benefit analysis of procedural application, a lot of our waste and our time delays that are costing the department money in processing, I think, can be handled with technology. but in ways that we haven't done before. I've done this in another state, and I know that it's a costly effort when you start changing systems. But CMS is an antiquated system, and there are problems in delivering good service. If you look at state agencies as a service agency, which it is, and making sure that people don't, from a taxpayer's perspective, don't take advantage of the system and get benefits that they're not due. But if we're really trying to bring down the cost of health care, and I have worked in hospital systems and major delivery systems to do just that, we've got to get people into the entry point earlier in their diseases and their health issues to treat them at the lowest cost possible. And we can't do that if we are delaying treatment and going to the ER for unnecessary care because we don't have insurance.
Again, I want to thank you, Cindy, for coming, and we just say why I think this is so relevant. We're getting ready to hear some discussion, and I think everybody's been reading the newspaper and understands that we've had a tremendous number of people determined ineligible who are getting cancellation notices over the upcoming days and weeks. Tens of thousands of people. And what concerns me greatly is that as we go through that process, we are able to deal with the results of that. And by that, obviously, nobody has a problem with people who are ineligible, as Representative Collins said, they don't need to be getting the benefits. But when we have people who are truly needy, or children, or people who are disabled, who cannot navigate the process and get the benefits because of letters that say they're in jail, or because they can't get the right person on the phone, or because of technology failures or software failures, we've got a lot of work to do. And so, I think this just demonstrates the point that we have got to get our affairs in order with regard to how we manage all of Medicaid expansion, and any of our other programs. And I had some good discussions again about some of the things that happened in Colorado with Cindy. And again, it's different sometimes from a policy perspective to do it than she's had to do it, and also to live it and experience it. So I got a couple questions now. Senator Urban?
Yes, Senator Hendren, I wish you had been in our meeting in Mountain View, because there was story after story like that of patients that are truly needy, that are Medicaid eligible. We cannot get eligibility numbers for. We cannot get Medicaid numbers for. We're floating those services for free in a clinic setting, in a hospital setting, because there's no Medicaid number and we cannot get a Medicaid number. Another story of a patient that they got a private option policy and Medicaid number. And they didn't want to waste taxpayers' money, so they spent 18 hours trying to make sure that they got rid of one. They couldn't send it, but a lot of people aren't going to do that. And the clinic had to work with them, the administration of the clinic had to work with that patient to help them do that, because they're trying to be fiscally responsible to the taxpayers. So I think that will be hopefully in the report that the Stephen Group was there and got to hear all of this. But there is a huge problem on that end of it, and I appreciate you bringing her testimony.
Representative Murrell?
And I guess it's along those same lines, because I guess we all get these same calls with horror stories of people getting letters of getting kicked off the system or not being able to access it. I guess Director Seeley was coming next, I think, and I guess maybe a question for him as we go back to boots on the ground, local access, and making sure that people. I know we got some IT issues in some other places, but even people have an opportunity to be touched locally, or they have someone there for local access to talk to them, help them through some of these problems that we're having. So hopefully, as he comes forward, that we'll be able to talk about that, because I think the frustration grows when people have to be on the phone 51 hours and et cetera, and not having someone that they can talk to and access person to person. And what the people I represent, a lot of them don't have the capacity to even go through some of the iterations that are required. So therefore, they become a discouragement and they stay unhealthy. So I think us rethinking this whole methodology of how we get to people, those that are most needed, I think is very important. Thank you, Chair.
Okay, if John and you want to come down and then we'll have a report from the Stephen Group. We're going to talk about how the progress is coming on this eligibility enrollment framework project. So we'll start with you all, and I think, John, you can have your team come down now later if you want, but John, you're recognized.
Thank you, Mr. Chairman. I'm John Seaver with DHS, and with me Susan Burton, who works on our EEF system. First, I appreciate Ms. Avery speaking. I mean, it's very sobering, and I offer my apologies. This kind of experience we never want to happen. You know, we have hundreds of thousands of people on the Medicaid system, but for those people who it doesn't work for, whether we should be getting them off or whether they can't get on, I know it's incredibly frustrating for them. That's why we feel such a sense of urgency for this new system to work better. That's why we're pressing IBM and the other vendors. We've got to get this stuff fixed as soon as possible.
John, can we stay right here for just a minute? Because here's my hypothesis of how we could have what seems to be completely incongruent situations. On the one hand, nobody can get on no matter what they do, and then on the other hand, everybody that is on deserves to be kicked off, right? It's just impossible to believe that that's actually the truth, right? So the only thing I can guess is whoever's writing the regulations, and there's probably 10 different groups, 10 groups in Washington, 10 groups in Arkansas, over a period of 100 years, where every regulation is written on top of every other regulation. And there was an old game in the 1960s called Twister, right? And if I wrote enough regulations, I could get it like a game of Twister, where nobody could make their hand or foot go on the appropriate circle no matter what they did, and so that you were always wrong. And so that's a theory that I have as to why it seems like hundreds of thousands can't get on, and the hundreds of thousands that are on all need to be kicked off. So if you could, if there's any truth to the theory, and you could give us some idea, here are the regulations that say turn left, turn right, turn left, turn right, so you're right back in the same spot after filling out 100 sheets of paper. I would love to attack them and would be happy to do it. So that's one thought on how we can have this unusual situation.
I appreciate that, Mr. Chairman. I think there's some truth to that. We have 60-something categories of Medicaid eligibility, and to your point, even if only 5% of our clients have difficulty, that's tens of thousands of people who are struggling. So we can be doing well by an awful lot of people, and still have a lot of people hopefully not experiencing a situation as bad as Ms. Avery, but who are still extremely frustrated, and we've got to get this stuff fixed. And I can tell you there are people working long hours trying to get it fixed. We're just not satisfied with where we are. So with that, Mr. Chairman, and I would also, I'm not sure if Ms. Avery's still in the room. I mean, she seemed to have some ideas for some improvements we could make. I'd love to visit with her. If she's not in the room, you can get me in touch with her, Senator Henry. That'd be good.
Okay. Go ahead.
Well, I'm just going to give you an update on where we are on some of these areas. So we have, what you just heard, these types of issues are many of the issues we're working on with our current vendor, particularly E-Systems. I want to let you know the things that we have had on their list in their statement of work in the last quarter. They did accomplish all of those things. We have made a number of improvements in the system. We're not nearly there yet. Lots of improvements still have to be made. We've still got challenges with newborns and others. But they did get a number of things done, so we're pleased with that. We are still negotiating with IBM, still have not released the funding that we're holding from them. They have continued to have some people on the ground at no expense and have made a couple of other offers of things that they can do for us, but we're still working with them because we're still not there yet in terms of what we need to see to feel comfortable that we're getting our money's worth and that we really have their attention on what needs to happen. I talked about the things that the improvements that have been made. The biggest, of course, is that we are now doing redeterminations. There were three big pieces that had to happen with this new population. One was getting people eligible, which we did at the beginning. That worked fairly well. One was what's called change of circumstances, where a family member leaves, or you lose your job, or something else happens, a significant change that would cause us to change your eligibility. And the third was being able to redetermine people's eligibility. And as you recall from our discussions before, once a year we redetermine people's eligibility on Medicaid and on the private option. But for the people in this new modified adjusted gross income, this large new category of eligibility under Medicaid due to the ACA, we had delayed that until the system could actually do redeterminations. When we met last month, we had just begun that process, and I think we had started about 10,000 people. We have now started 225,000 people. They're somewhere in the process. So we are going kind of full gun now at determining these people. We have 600,000 people that we need to determine eligibility for, redetermine eligibility, and we have at least begun the process on 225,000 people. There are two different categories of people that we're working with. People who are in this new system, this Purim system, the IBM product, and then people who are still in the old eligibility system that need to get moved over to the new system, so they're all in one system. For the people in the new system, what we do is we bounce against, and some of this you've heard before, we bounce against the state workforce data, their wage data, to see if their income is, these are all people who were determined eligible initially. We're now looking at their income data saying, has your income changed more than 10% from when we determined you eligible before? And if it has, we send you a notice saying you need to, within 10 days, get back to us and verify, and give us the information to verify what your income is now. A check stub, a letter from your employer, something else like that that verifies, or the unemployment notice that shows you're unemployed, for example. Verify what your income is now. If you get back to us within 10 days and that information is good, then we continue on the rolls. If we don't hear back from you in 10 days, we will send you a notice of termination, saying that at the end of the month, your eligibility is going to be terminated. So what happens, so in practice, let me explain that, and to let you know, we have now sent notices of termination to about 25,000 people. Nearly all of them are on the private option, and nearly all of those, the terminations were because they did not get back to us. So we don't know that those 25,000, that their income is changing, they're not eligible. What we do know is they have not gotten back to us in time to verify their eligibility. So here's what happens in practice. We give them a 10-day notice. We then add about 5 days because we want to make sure we have at least some time for the mail and for the processing. Then when they get that notice, let's say they don't get back to us after the 10 days, which is effectively 15 days if we don't have something in our system saying we've heard back from them. We'll send them a notice saying that you will be terminated at the end of the month unless we get additional information from you. We're required by federal law to give them a 10-day notice of termination. So in effect, there's the 10 days where we say get back to us. We added about 5 days just for the mail and processing. And then there's at least another 10 days that we have to, that we're required by law to give them that you are going to be terminated in 10 days. So in effect, there's at least 25 days where if they get back to us and we're able to process that information, if they get back to us in that 25 days with information that says I am still eligible, such as their check stub, we can just leave them eligible and they won't actually be taken off the rolls. If we don't hear back from them in that amount of time, then we do terminate them from eligibility. And most of these are in the private option, but there's a good number of them who are in the regular Medicaid program, but in the new eligibility system. We would then terminate them, and then we're required by law to give them 90 days during which they can still come back to us with information if they are indeed eligible. And if they give us information that shows they're eligible, we can make their eligibility retroactive to the date of termination. So, I mean, in effect, you've got that 25-day period plus another 90, during which people can continue their coverage. But I want to be clear, after 10 days, plus the 5 days for processing, we send them a notice saying you will be terminated, and if we don't hear back from them with that information, they're off the program. Does that make sense? Let me ask Susan if I've missed something in that description. I'll talk about the other group here in a second, but I want to see if that's clear about how, so this is for about 200,000 private option participants. Obviously, there are more than that on the private option, but some of them haven't been on the rolls for a year, so they wouldn't be due for redetermination. And this also includes about 150,000 from the regular Medicaid program. These are children and adults from the regular Medicaid program, but who are in the new eligibility system. All of those 350,000 people, between now and October 1, we will be looking at the income, we'll look at the family income, we'll be looking at the income and sending all of them a notice either that we've looked at it, you're good to go, but tell us if we've missed something. In other words, if what we verified is wrong, tell us. Or you have 10 days to give us that information. We have determined about 65,000 already to be eligible. So the 25,000 we've taken off, 65,000 been determined to be eligible. Again, those are nearly all private option clients, because as we talked about the last hearing, we really started with the private option clients. We're catching a few others because there may be a child who's in the private option family. The child's on regular Medicaid, so it's not all private option we're looking at, but that's really what we're starting with.
Okay, let me just clarify a couple of things.
Yes, sir.
You said you tested 225,000, or you've run that many through the system, of which most are private option. When you say that means that 200,000 of them, 150,000 of them?
Yes, and of the 225, actually, when I talked about starting 225, that's in both groups. The second group I haven't talked about yet.
Okay.
Probably 150 of those, roughly, are in this first group, in the private option and other group.
Okay. And you said right now 65,000 have confirmed eligible. I guess what I want to know is out of how many that you verified.
So we have, the challenge is, of course, we're in a rolling kind of 10-day period. So some of them that we started with, they haven't hit the deadline, so we wouldn't know yet. In that first group, of the 140 to 50,000 that we've looked at, 65,000 we said you're good to go. 25,000 we've said you passed the deadline and you can get back to us. The remainder would be ones who are still kind of in that.
So like I say, it's kind of a rolling number, so while you tested 225 when you showed 65, there may not be 225 that have gone through the 10-day period.
Right, but most have not. And some of those 225 are actually in the 30-day period that I'll talk about.
But would it, another way of saying that be though that everybody except for 65 has gotten a notice that they've got 10 days to provide us verification?
No, sir, because about 75,000 of those, I'm sorry, of those 225, about 75,000 are in the second group I'm going to talk about.
Okay.
They have gotten a notice, but they're in a different group.
How many have you actually terminated the policies on? Not just sent notice of termination, that you notified them, sent them a 10-day prior termination that
It would be very small, because they would be terminated at the end of the month. So in this, like those 25,000, virtually all of them will terminate at the end of July when we actually turn them off that bill.
Okay. Have you had any feedback from the insurance carriers that this is going to cause them to ask to adjust their rates if you have tens of thousands of cancellations?
No, we have not. And we probably just, I mean, if it turns out that there are tens of thousands and it looks like they're not coming back on, and there already is some indication for those that we've sent the notice, you get turned off at the end of the month, they are starting to come back in and say, wait, here's my information. And let me just say, this is a new system, a new redetermination process. We have trained our staff that I am sure there are some people who have sent us a notice, have sent their information, it's somewhere in our system. So there are going to be some people who you're probably going to be aware of who have said, I've sent in my information, DHS didn't get it. And I mean, we're going to hope that it's not a large number. Anytime we have a new system like this, it's going to happen. It's going to went to the county office and they didn't forward it to the right place. I'm glad that's why we have this buffer of extra time afterward. But there are going to be, I want to be clear, I'm not telling you everything's going to work smoothly with this many people with a brand new system. So I'm sorry, Senator, go ahead.
Well, why is the program that we spend all these millions to develop not sophisticated enough to do? Because the way you've explained it is that there's a 10% variation, they got to re-verify.
Yes.
And I guess what I'm wondering is, if somebody's at 16% of the poverty line and they go to zero, why would they have to re-verify? I mean, why can't the machine go, obviously they're still eligible.
The federal requirement is that we have a reasonable compatibility. In other words, what we see in the system has to be reasonably compatible with what they reported to us. And that definition of reasonable compatibility, it's got some complications, but basically it is, if you are 10% above or below, basically 10% variance from what you reported when we looked, you have to come verify.
So even though we can say with certainty that the change from, or the same thing is true for people on the private option, they go from 100 to 112 or whatever, why it's going to have no impact on the program, but we still have to put people through this process because of some federal.
Yes, sir, we have to verify the income. And if it's more than 10% away from what we have in our system, we have to ask and get some verification of it.
Yeah. Okay, Senator Irvin, you have a question?
Yeah, and that's annual, correct? You have to reapply for Medicaid annually, same with private option?
We have to redetermine terminating them, yes, ma'am.
Okay, second question. The 90-day that you just described, what about healthcare services that are rendered in that time frame?
So if, in that time frame, if in that 90-day period, you come in at any point and get redetermined eligible, it is retroactive, eligibility is retroactive back to the date that you were terminated.
Okay, what about if you are ineligible?
But if you're ineligible, then you're still ineligible. I mean, if we say you're gonna be terminated in July,
Right,
and 2 months later you come in and say, here's my information, and it turns out you're not eligible, you were still ineligible at the end of July.
right, okay, but what about healthcare services? Are they gonna have to be recouped, or, like, what if claims in that time frame?
We would not pay the claims for someone who's ineligible.
Right, okay.
I may not be answering your question there.
Yeah, I'm just saying, would the provider know that they were ineligible
Yeah,
or not ineligible?
so at the end of the month, their card, when you check their card,
Right,
would show that they're ineligible.
gotcha.
I mean, and I didn't get to this, we met with providers and carriers this week to talk about this. Obviously, one of the things we're encouraging providers to do is when they see clients who are on Medicaid, to say, if you get something from DHS, make sure you respond. And I would say at that point, if someone comes in with a Medicaid card or private option card and it turns out they're not eligible, I would encourage providers to say, hey, if you think you're still eligible, you need to get information in, because otherwise, as a provider, that service is probably not going to be paid for.
Yep, that was my question. And then finally, we may be addressing the newborn issue. It seems to be why is that? Why is it difficult? Is it because of the transition?
Well, the short answer is that, and IBM has agreed with this, that is a defect in their software. They did not build that component in. Ms. Burke can probably respond to exactly what happens there.
I just didn't know if it was because of private option versus traditional Medicaid, and if it, if we were switching people over back and forth, and that's why, or I just didn't understand it, because it is a problem.
Right. Under federal law, if you have a child eligible in the newborn category, it's supposed to go back to their date of birth automatically. The mother was Medicaid eligible at the birth of the child, including the private option. And that's a federal requirement. It is not in the IBM software. So what we're experiencing right now is that is a totally manual workaround for a caseworker to pick that up, that day, all the information, so the child is covered back to the date of birth.
And that's why that's when you refer to us having to go in by hand and do
Yes.
these.
Yes.
Yeah, there's a lot of them out there.
There are.
Okay.
And we're hearing about it, as we should.
Yeah, well, no, I mean, it's
So, Senator, would you like me to explain this second group, or I can continue to answer questions about the first group?
Let's got a couple. The second group, just real quickly, because this may affect some of the questions that are coming, and I want to
Sure.
go back to these.
So the second group are people who are, for the most part, were Medicaid clients already and are still in the old, our answer system, the old system. For those people, we're actually asking them to come in to the new system and what we call to renew, to actually put in information, because there's information we need that we don't have. We can't just shift their information over. Because we're asking them to do a little bit more work, we're actually giving them 30 days to come in and put that new information in, and then after that, kind of the process works as we just talked about. So they've got a little bit more time, and we're doing those in chunks of 25,000 a week. We are sending out 25,000 notices per week to these individuals, about 250,000 of them, so it'll take about 10 weeks to say, please come in, renew your information, so that if you remain eligible, you continue to be eligible.
Is this all traditional Medicaid people?
Yes, sir.
Representative Murdoch, correct?
Yep. Right, they're Magi people, they're in the old system. But there wouldn't be any private option in there. I mean, if they were, it's a mistake to put in there.
Okay.
So, Director, what are we doing at the local level? I heard you mention a little bit about county offices, because, again, the people that I represent, a lot of them have capacity issues. You're saying that you're mailing out, you're contacting, and sometimes, addresses change. So many things happen in their lives. So what are we doing from the county level, local level, to make contact, get engagements for either eligibility, renewals? What are we doing?
Susan has worked at the county office for years and is now working this, so I'll let her describe how that is.
We're doing increased training with our county office staff so that they have the ability to handle anything that comes through the door. So if clients come in with questions, we're also, we've met we've had increased calls everywhere, so we're also moving some of those calls away from our processing center and our call center back to the county office. So what you're going to see is that clients are going to have more interaction with their local county offices than was originally anticipated.
So are we staffing those local offices so that they can do any outreach? What I'm looking for is some outreach to communities so that they can engage better. Because we have, right now, this week, I've had 2 or 3 calls that I haven't called you over yet, where people have been letters saying that at the end of the month, they're not going to have coverage also. Now, their situation has not changed. They still, are eligible, but based on income, nothing has changed. They got these letters, they don't know what to do, they make calls. So what someone doing is calling, you had some outreach people a while back that was a part of this process months ago. And they are reaching out to some of those organizations, those people that work for the outreach program and asking them what to do. So there's a big disconnect and people get discouraged again. So I want us to hone in on part of this and try to solve this problem, to figure out maybe going back to the old-fashioned way, I call it boots on the ground, and really getting out to the community and engaging with people and letting them know that there's help for them.
Yes, sir. The outreach that you talked about.
Because the IT way, because the IT way is really causing us some problems with making that work.
Right, well, I want to say that the outreach staff who did outreach on the private option exchange were not our staff. They were from different community organizations, and we did not add any staff for them. So we have not added any community-based staff, and it would be difficult for us to do. I mean, for instance, our county administrators might be able to come talk to a group, but we don't have workers that can go out and do outreach in the community. They are working full-time, doing the processing in the county offices.
Sure, so if we could contract for these multi-millions of dollars with these IT firms to try to make all this come together, I think we could take a fraction of that cost and go locally and outside contract with some of these entities that we know do a good job with closing that gap. And it won't cost us nowhere near the money. It will make us a whole lot more efficient in getting real information in, dealing with real people. And, I think it would help us a lot more than this. We got a disconnect here, that I think we can fix efficiently and in a manner that's very efficient, even when it comes to cost.
I think it's an interesting idea. We are, that type of outreach right now, we're really trying to do more through the insurance carriers and through physicians and others, who are locally there. We just don't have the staff to do it. We are working, talking with one of our contractors right now about whether they could help us stand up more call center capacity. As Ms. Burton talked about, we are trying to send some of those calls to the county office and do training, but it's training on a complicated system. So this is a real challenge. There's no doubt our system right now, our customer response system is overloaded because we're doing so many redeterminations right now. Again, I'm somewhat comforted by the fact that there is this extra period to come back in, but it is frustrating for clients that if you're able to do what we ask you to do, in other words, you can just send in your pay stub, it is not a complicated process. If you've got questions, it's hard for us to be very responsive because there's just so many more people than our people on the phones can handle right now.
Thank you.
Okay, Senator King, you recognize.
Thank you, Mr. Chairman. Director Seelig, whenever you're doing these redeterminations on the people according to the Affordable Care Act, you're supposed to do redeterminations on the PO people every year.
Yes, sir.
One time a year.
Yes, sir.
So it's pretty easy to scam the system. When you do the redetermination, they could quit their job, get back on the PO, then turn around and get a job and stay on the PO till you do it again and send them another notice.
Well, that would be true with Medicaid also. We also do Medicaid once a year, and that they would run the risk of having real issues with IRS if they didn't report an income change.
But you're not going back and making them pay the money back. But you see what I mean, the people on Medicaid who are disabled, then more likely you're not getting a job or something like that. PO is able-bodied working age adults. So you send me a notice in March that I am over the limit making money, okay? I then go and quit my job, apply then I get back on the PO, so I don't have any income. Then I can go back out and look for another job and keep health insurance, real good health insurance, that the average Joe out there has to pay more for less coverage. And I can stay on that PO again until the next year you do it again. I mean, it doesn't matter what you report to the IRS, because you're gonna have to pay taxes on that, hopefully. I'm talking about just your system, not the IRS.
Yes, so when you come back on the private option,
Okay,
we would say to you that it's your obligation to tell us if your situation changes, and you would face potential penalties from the IRS, or the federal government, I think it's from the IRS, if you end up having income that you didn't report that caused you to not be eligible for the program that you stayed on.
the people that have already, now that you're checking, they have already, if they've got a job and receiving that income, then you're not required to go back and pay the money. So is the IRS going to come in and penalize them for these people you're finding now?
Well, I don't know whether they would, and again, most of the people who we are taking off now are people who have not responded to it, so we don't know whether their income, whether they're over the limit, or whether they simply haven't responded, or have moved out of state, something else may have happened.
But you just said that the IRS can come in and check you, but then you just said that the IRS probably won't do that. And those people will keep doing that. I mean, you see that in rural communities, you see it at times, that they figure out the system, and they just keep doing it until they get caught. And then if they do get caught, as you said, you're not going back after them, which if the IRS or DFA overpays me, I'm sure DFA probably knows my finances pretty well, but if they overpay me, they're going to get their payment back. A farmer goes out here and applies for some type of relief from government, with disaster relief or everything, they misfill out everything and everything, they can come back and get it. You're giving them a total free pass. So people know that, and that's how they can figure out and work to scam the system.
Well, I think if they are not worried about facing those penalties, if that doesn't bother them.
They're not worried about it, because you've already said in the newspapers multiple times, they're not worried about you, we know that. You said in the newspapers multiple times that you're not going back at. So
All right, let's keep the discussion on what we're talking about here, the eligibility verification process.
Well, that's why I'm talking about the process and trying to figure out how people can't scam the system. I mean, you're going to have a system that month to month can figure out where their income level changes and start making them pay the money back.
I would just say, Senator, I think one possibility that we've talked about is, right now the federal government says you can only look once a year, you can only redetermine once a year. I think that's one of the topics that we potentially ought to be talking about with the federal government is, could we look more often? And you want to see what it would cost us in terms of state administrative expense, that may be something we want to consider, is looking more often at income.
So to be clear, what you're saying is right now federal law prohibits us from checking more than once per year.
It prohibits us from redetermining more than once a year. So in fact, you can check, but kind of the point in.
But you cannot have a redetermination process more than 12 months, but that is something that could be part of a request for a waiver.
We can at least talk with the federal government about whether you can get a waiver to do that. Yes, sir, I think so. I mean, we can certainly ask. Right now the rule is once a year.
Senator King, go ahead.
Well, I mean, that just gets to the point. You're saying that the federal government prohibits you from checking multiple times each year.
Yes, sir.
Okay, but the federal government in the law forced you to check once a year. You didn't do that, and you got a waiver to not do it. So you could check about a waiver to check multiple times a year.
Yes, that's what I was just saying. I think that's one of the things we could do potentially is go back to the federal government in this successor to the private option and say, one of the things we might want to consider is, could we check more often or check differently?
So I'm in a border area up there, Borders, Missouri. So if I sign up on a private option early on in the fall of 2013, got on the private option to get this great health insurance at no cost, then I could literally a month later have moved to Missouri and still be using the card and the health benefits in Arkansas. That is possible, right?
That's like, if we didn't detect that you were now living in Missouri and you didn't report it to us, that's possible. If we know you're living in Missouri, we would take off the program.
Take off, but you're not going to require them to pay that.
Not at this point, because we don't have the capacity to go in and find out exactly when you moved and those types of things.
And this just issue, but it's just like, right now, there's a lot of bragging about going on the price per month cost that you're under, the second figure you come up with, not the original figure. But in the real world, it's just like a bank. If they give 100 loans and 20 of them default, they just don't brag about the 80. If you go back to shareholders or whoever you're accountable for, the total cost is figured on the waste and frauds. And when I worked in the construction business, when you went out and bid a site, the amount of money, the amount of lumber that you lost, the amount of lost time that you paid out that wasn't due, all that was figured in the cost. So all this bragging about we're under this cost is really misleading people. It's not the true cost. So I guess, Mr. Chairman, I'd like, whenever they come up with redeterminations later on, we need to refigure and be truthful to the taxpayers about the true cost per month, because it needs to be figured in the amount of money wasted, because you can't go to the bank and just say, hey, you know, don't worry about this other part that I lost. Let's just talk about what I actually did. And so maybe in the Stephen report, when we get at the end, to figure out the true cost and be truthful to the taxpayers, this 3-month figure that they're bragging on needs to include the amount of waste, fraud, and abuse in that, because that's what the true bill to the taxpayers is.
Mr. Chairman, there just may be some misunderstanding. We capture all the cost. If, as Senator King identifies it, if some of those people shouldn't be on there that are spending money, we still capture that cost when we show the cost. We're not kind of discounting that cost.
Okay, again, we're out here to, we're going to have a lot of discussions and have had about the costs. In fact, that's one of the items on our agenda that we're trying to get to today, is being able to really document what it is. Senator King, do you have anything else on the eligibility system? Representative Ferrari, you recognize.
Thank you. I just got to know what Senator King was alluding to. Does any of these companies that we've got under contract verify the Social Security system? And if they have to report once a month income, can we not cross with Social Security for the federal, on the federal level?
We don't check Social Security for income.
No, could you cross Social Security and check, verify income on a monthly basis, because you have to report monthly, I mean, we have to report our non-employee ones to Social Security. You know, could you do that by one of these companies that we have?
That's actually considered a redetermination of eligibility, and we're prohibited from doing that right now under the federal regulations.
But we could, well, I guess, I know we are now, but on the companies we have worked, all these vendors that we have working right now, could we have one of them to solve Senator King's problem once a month with the Social Security?
I think there are potentially many possibilities here of what we might want to ask for as part of the successor to kind of ensure the integrity of the system and the integrity of who's on it. So it may be Social Security, it may be IRS, it may be, now there's some data that's a lot older than our state wage data, so that's not particularly helpful. But if there are things we can check, one of the things we want to do, we'd like to eventually hook up to workforce services so that we can not only check income in the state, but with the surrounding states. Right now, that would have to be done manually, but there's a possibility of doing that automated. So if somebody lives in West Memphis and maybe also has some income in Memphis, we'd like to be able to capture that. So that there are improvements, I think, and maybe that's part of what could be proposed, would be how to do this.
I think we just make it wrong, but I think the Social Security, checking the Social Security works across state lines, it's going to be reported because and you can't cross state.
Okay, and again, I think we all share a goal that you include DHS, that we have a system that can give real-time verification. That would be ideal. But obviously, federal requirements and laws may prohibit that, but we can try to work through that as well. But certainly, we all, as we heard earlier, it's important that we be able to verify who's eligible as well as who's not eligible, and we're all waiting there. But anyway, okay, that's all I have on the list. You guys can stay put if you want, or I think you're going to have another question or two in a minute. John, Stephen, and your group, if you all want to make comments on this redetermination, I don't think we need to beat this for hours because we've got some other important things to get here too. But I know you all have been working on this as well, so I'd like to hear what you all have to say about it.
I'm going to move on here. Yeah, looks like it.
Mr. Chair, I want to be mindful of time and try to get through this quickly. We're going to, let me just find the slide one. We're going to talk about, there's two things here. Martha Tuttle's here to talk about the framework contract and the issues that she has looked at in the last month for the update for you folks. I know that it's been a long day. Jason Melanson from my team has strong IT background, has been working for us to try to identify these redetermination issues in the process. And we've looked at other states. We've contacted a number of other states on eligibility system issues so we can answer a lot of questions. We've raised some issues with you that we've actually seen, and we wanted to make sure that you're aware of that. But just to kind of go on the end of this discussion with Director Seeley, your information that Phil has given to you in copy has slides that outline the redetermination process as we see it. There are a number of slides there that you can review on your own. Our status report has a pretty good detail of the eligibility process. I would say that in our review, there are some issues, and I think Representative Murdoch brought this up. I don't think there's a lot of outreach in the community here in this state. Other states have a lot more efforts through faith-based, through other groups, through child welfare agencies, through foster kids, through all the things that you pay for as taxpayers as well, that you could do a lot more to make sure you educate them. Then we have on the other end, and we've outlined this on our slides with regard to the system, there's what I would call leakage. There's issues that you need to, and I think maybe Representative Farrar or someone brought up, as you go forward to your solution. And I don't want you to so much focus on the past as much as the future. When you design the solution, the entire solution that arises out of this project, you know, how do you make sure that you take care of all those issues going forward, even if it takes a few more years? A question we raised, incarceration. To make sure that your system is able to identify from which they don't have connectivity today direct, to know that if someone is incarcerated for a significant period of time and they're on the private option, that you're not paying a premium during that time period. To make sure that when someone is deceased, that you don't have to keep recouping, that you identify from vital records at your Department of Health in real-time capability. And I know the department is working on those issues, so that at the end of the day, you're able to identify quickly and efficiently who should be on the program, who shouldn't. And then the final thing I would say, and Jason's going to be working on this, and we're going to get information for you on our final report, and this is all part of our scrub as well. The one area that I brought to your attention early on when I was meeting with Susan and the staff, they are following federal law that says, or federal rules, that can be waived in my opinion, and I will verify that for you before the final report. And that says that the redetermination process shall take place every year in no less than 1 year. So what that means is someone finds employment in month 2 or 3 while they're on the system and puts them outside of that 10% above, and they're no longer eligible and they go into maybe a subsidy category, you will not find out about that unless they self-report. And what we're looking at right now, working with Workforce, want to thank them for working with us. Because of the federal laws and state laws, we can't get access to the system. We have given them our tool that we're using to analyze data, and we're going to train them on the use of that tool. And then they're going to give us information on what they found for you in the final report. And what we're trying to see is it a possibility that if we say, you've been on for 6 months, I think we're going to stop at 6-month interval. And has the employment changed that dramatically within 6 months? And now you can see if it's an issue. So what you eventually want to get to is what I think they were alluding to is a system that's able to identify these things quickly, efficiently, rapidly, real time, as much as possible. That's the end game that you want to look at. And Jason is here to answer any questions you have, but I know I want to be mindful of your time. Our slides, we go through what we have identified on death certification, what we've identified on incarceration issues, what we've identified on the normal redetermination process, and Jason continues to work with Susan and their staff, and we'll have a lot more for you as we go through the next few weeks and months. Now, with that in mind, Martha is also going to be talking about the actual contract, but I wanted to, while we're talking about that topic, just to let you know, Jason's here to answer any questions.
Okay. Jason, do you have any presentation, or you just want us to ask questions?
Jason Mulligan, the law firm here in Arkansas. It's one thing I'd like to quickly mention. I do a lot of review and assessment work, have done for decades. I'm usually dealing with walls of obfuscation and delaying tactics, and I have not had any of that here. Both the DHS and the other Arkansas State Departments have been, in my experience, almost uniquely forthcoming and responsive. I would say that John was alluding to the key fact that making some changes for Arkansas in regard to certain federal regulations is key to a number of things you do to improve your processes here. One that we didn't mention was that right now the state, or that hasn't been mentioned yet, is in the initial income determination. You're required by the process that's been approved by the feds to use the federal data. The federal data is fairly out of date, and it would be, and this is probably a significant contributor to the fact that only 20% of the initial assessments of income are approved on one pass in the initial eligibility determination. It's a hands-off percentage, if you will. If the state was allowed to use the unemployment insurance database and other local and more current sources of information, you might be able to dramatically improve those numbers on the front end. But right there, you're handcuffed by your current federal agreement. And then the increasing the periods which you're allowed to reconsider income. And it might be as simple as John was talking about, that you in a 6-month basis rather than an annual basis, and we're investigating whether that is worth recommending you to pursue or not. But it could also be that there might be targets of opportunity. You might use the new hire database as a reference point, and then say, okay, that's a target of opportunity. Let's go look at these people who show up on the new hire database because they are likely to have made a meaningful, a material income change. And right now, you cannot intelligently go cherry pick the opportunities of redetermination. You simply have to go through this ka-chunk process that's been defined with the feds. That's another area where you're looking for a change in your relationship with the federal regulation you're operating under. And then
Let me just ask a question. Is there any state that has sought a waiver from the federal government with regard to verification so that they can have real-time verifying?
I'll take this. I've actually contacted a number of states. The real-time verification, there's a number of states that are working on right now, but not for the income. There's no state that I'm aware of that has anything on the income less than 12 months, 1 year. And I believe if we find what I'm thinking we may find, we're probably going to recommend to you that in your waiver going forward, that maybe Arkansas be the first state to do this, but that you do it more routinely in an income check than 1 year.
All right, we've got a couple of questions here, and then we'll move on to the next item. Senator King.
Mr. Stevens, maybe I didn't make my request that clear, sometimes I don't communicate. What I'm trying to do is, when I say trying to find out the true cost is, let's make it simple, about these people that don't qualify and the people that do qualify and the cost of the program. And what I'm looking for is let's say you have 10 people on the program costs $100. That's $10 per person. But if you only have 5 people that actually qualify for the program, and you look at that cost versus the people that actually qualify, you're talking about $20 per. Now that's what happens in the real world in the business world, if you don't, you go bankrupt. And I mean, it just shows how this kind of stuff is just bankrupting our country. And that's, do you understand what I'm asking
Yes.
for? Whenever you do the cost and the redetermination of PO, I want the actual people that qualify and the cost of the program, and then that's going to give us our true cost, what it's doing for the people that work on it, that it's supposed to work for.
Yeah, I mean, I understand what you're saying, we'll give you estimates, and the issue is, and then what I've seen in other states, and this is where it becomes problematic, and I'll use the state of Illinois as an example. You know, Illinois saved a few $100 million when they first implemented through cost avoidance because they had much stricter procedures on the front end. But they put together this through a legislative act called the SMART Act. But they brought in, and I think Representative Hammer at the first hearing was mentioned, is they brought in a real large workforce that they figured an ROI, let's hire, I think the contract was maybe more than a couple $1 million. But there was a number of workers that came in that really had a very proactive effort, and also involved the community side too, notifying folks. But they can do it that way, or you can rely on assistance. And so in our final report, we're going to give you some ideas, and we're also going to try to do the estimate on potential, leakage and savings that you could have by fixing the system in the way that, we'd like to see you look at.
Because in future assessments going forward, when they want to add programs or do something, you have to figure in, no matter if Ron King comes up with it, as I mentioned, construction, you knew when you go into the thing, what your estimate was going to be on waste, fraud, or whatever. So it would give you, if you're having a 50% program, and then you're telling people from the future, the program's going to cost $100 per person, when really, if you look at the whole thing, any program that you go forward, if you're going to be honest and truthful with the taxpayers, you're going to have to tell them up front, this is the estimate that we have on the amount of fraud and waste that we're going to have with any particular program. And then you get what the true cost of the program, because it's only meant for the people that are qualified, and to just discount and just say, put it across the board, to me, is not being straightforward.
Okay, again, we don't want to have discussions, we want to have questions, so we're going to go on. Senator Ingram, you got a question?
If that holds true, then you would need to look at the other side of insured lives on what it's costing people that are paying premiums, that are building in, they're paying for people that don't have insurance. Wouldn't you agree with that, Senator King? I mean, you're looking at it from one side. Obviously, we would all like to know how much is built into our premiums to pay for people that don't have insurance. I mean, that's the other side of the coin. But the question I've got, would you research and look and see, I'd be very interested to know, if any other state has a program that they train their, have an outreach program that trains their eligible people to lie to other states so that they can get on the other state's program instead of on Arkansas's program. Thank you.
All right, Senator Urban and Representative Farrar.
Quick question on those that are ineligible, and I think it was Senator Hendren or Representative Collins that brought this up that I hadn't really thought about, but there is where we pay for benefits for employees that are not in that position in order to keep premiums down. So if there's a large number that are ineligible or that are removed from the system, and I support that, but is there a tendency for us not to want to do that because of the premium imbalance that might occur because of that? Does that make sense? Because of the nature of the private option, we're purchasing, there's a nature of the private option where you're purchasing policies, insurance policies. So your pool of people are directly related to your premium cost per month. So how would that eligibility fluctuation affect the premium monthly.
I'm not sure I can give a very good answer. If the number of people at one of our carriers has changed significantly, that's what you're talking about.
Yeah.
I think it would depend on whether they thought the mix of clients that they had also changed. In other words, if they thought the old people got off the program, then their premiums could go down because younger people are healthier, vice versa. And at some point, if the numbers dropped enough, I mean, some of the carriers came into this market because of seeing about 200,000 people that they thought would be coming in. If that dropped enough, they may say either we don't need to be in the market, or by the time we figure out our administrative costs across a smaller pool, that the premiums could go up, I think. Now, I'm not an insurance expert. Just some conversations I've had, I think some fluctuation is probably not going to cause that. But if, at the extreme, we went from 250,000 people down to 150 and it stayed there, budget didn't come back on, I would guess it would have an impact on premiums.
What about the fluctuation, I mean, real-time eligibility check, I support that. But the nature of what we've created with the private option will have a factor that there will be an effect, correct? So I don't know if that's being taken into account or not, but I think it's something we have to look at.
I think it's good.
Okay, Representative Ferrari, right now.
I'm going to be a little unique here. I want to go back to the report and some questions. I was on the report card in terms of we were insuring prisoners, deceased folks, and people over 65. How have we addressed that? Have we addressed the fix of that? I'm getting, I think we work in prisons. We're having people from DHS from the prisons and enrolled prisoners. I mean, that's not true.
So that, first of all, I think it's not through the DHS. I think there are brokers out there who, for prisoners who are leaving, and we work closely with corrections, particularly community corrections, because the idea is that if someone is leaving prison, we need to make sure they have health coverage when they get out, if they're eligible, particularly for things like behavioral health services and substance abuse. So,
No, we aren't enrolling people in prison.
Well, no, sir. My understanding is the way it's working, first of all, it's not our employees, is that if corrections says John Seeley is leaving the corrections department in 3 weeks and will be outside, they're coming in and taking the information so that when I leave, I'm then eligible, because they're not eligible until they actually have left. We cannot pay for Medicaid coverage when they're incarcerated.
Right.
Okay. And to my knowledge, we're not. Now, if there's someone who's incarcerated, and I think, Susan, we do checks with the corrections about who's incarcerated, right?
We are currently checking out our legacy system, and we check an application for the people on the private option and at redetermination, but in between we do not currently have a monthly check, but we are working toward that. But we do have a monthly interface, not a technical interface, but we do interact monthly with the Arkansas Department of Health for the death match. And so as soon as they report to us that someone is deceased, we immediately take them off as of the date of death, and if any payments, if any premiums have been paid, those are recouped.
Okay, but the people that's going to be in prison, when they're okay, let's re-enroll them in prison, they get out, they go back to prison, we're still on the private option.
Right, and we are.
Or you?
No, absolutely not. As soon as we determine, and we do have an agreement with the Department of Corrections that we're working toward, that they will let us know immediately when someone becomes incarcerated.
And I would say on the private option, it would also be hard for them to use the Blue Cross card in prison. I mean, practically, I don't think they.
I have prisoners in my hospital, and they present Blue Cross Blue Shield.
Well, now, if they're out for a day, if they're, as you know,
I know.
they're having a nice day.
Okay, so the deceased, okay, let's go to the deceased, we were $23 million on the deceased. Okay, and in the report, it said, that OIG said they weren't eligible, but MMIS put them back on. Explain, we got it.
Right, we have fixed that. I believe that was 17 people. That was through a very small system glitch that we had. Those have since been taken off, and their payments, if we made a payment, it's being recouped.
17 people, $3 million?
No, initially, the 23 million was the people that we had on initially. All of those have been taken off and recouped, yes.
So you're 100% now that we have nobody's dead on the.
I will tell you this, that the Arkansas Department of Health provides our information to us, and they are dependent on funeral homes reporting timely when people pass away. So if the funeral home doesn't report for a few months, then the Department of Health doesn't know, nor do we.
Is there a better way than relying on funeral?
But they're also unlikely to use their card.
Exactly.
Well, yeah, I know, but we're still paying the premium.
Right, and we do recoup those premiums.
Right, we're still paying the premium. So we've got that fit.
We do, yes.
That's the 65-year-old.
The 65-year-olds, our system anticipates currently when someone is going to turn 65, because we don't cover those people because they're eligible for Medicare. That's one of the eligibility requirements under MAGI. So at the end of the month, before they turn 65, if their birthday's in July, at the end of June, at the 1st of June, they're sent a notice telling them that they're probably eligible for Medicare and they need to go make that application. And then their coverage is terminated at the end of the month before the month they turn 65. And we are systematically doing that now.
So
Yes.
we got all this fixed, we've got a better process. John, we have a better process to fix this problem.
We absolutely do, yes.
Let me ask John. John, is there a better one?
I think the OMIG is here as well, and they did find some problems, and so that's what we reported to you all. And then we met with the staff, and we did recognize they are working on these, and they did correct those issues. There was a corrective action plan put in place when the OMIG issued its audit, and we're still reviewing it though, Representatives. We want to make sure in the final analysis, what Jason's going to do, working with Susan, what we call quality assurance. So we can kind of give you an idea and we'll be in better shape to answer that full question. But I can tell you that the issues here, we've seen that they have addressed.
I want to ask you this, is the fix that they've come up with is something that you would recommend?
Yes, but the system needs to be improved. And everybody would agree to that. And so when we go forward, we're going to try to give you some recommendations to stop the leakage that you people care deeply about because it's a public integrity issue. And the OMIG identified those as well. And I think you need to do a better job in this state in terms of public integrity. And I'm just going to be honest, other states provide more resources in public integrity issues than this state. And that's something we're going to address in the final report.
Okay, it looks like one more. I've heard that a lot today. All right.
Okay. In the report, I just want page 35. This sentence bothers me, and I'm just going to ask you. DHS hired Gartner to assess the bigger picture of whether a firm is the right product for DHS. So we hired another vendor to check on another vendor. That's what I read.
Yes, well, and I should have done this in my overview. The Department of Information System and the Governor's Office work with us. This system that we have, we want to be sure, we as a state administration wants to be sure that in the long run, this QRM system that we have, that we're implementing, is the right, basically the right system. It's going to give us the best value in the long run. So this QRM study is to look at, it's to look at the other vendor. It's also to look at how we manage that vendor, how we do the procurement.
But then we got to hire another vendor to check on a vendor.
Apparently this Gartner group is the best in the business at doing this, so I think the answer is yes. I think the Department of
What if we hire Gartner group to do instead of four or four?
Oh, the Gartner group, all the Gartner, I think one of the reasons DIS recommended the Gartner group is they don't do any implementation. All they do is studies like this so that they don't have any conflict of interest. So they don't have a system themselves, they don't implement systems, they just study systems and say, is this the right system?
So they're a company that checks on other companies.
Yes, right.
They are considered the market expert in knowing what software exists in the marketplace. Because one of the questions that people ask, is there an alternative to Kura? Because we've all heard all of the words and problems with Kura. And so you need to answer the question, is there something else out there? They are a company that surveys the marketplace constantly to look at answering that question.
Wouldn't it have been smart to go to Gartner? I'm sorry. Wouldn't it have been smart to go to Gartner and say, what's the best company?
Well, I don't know. That question is very that question is multi-dimension, and I don't know that they can answer all aspects of it, but they can at least say, Is Quorum a viable product, which is an important question to answer, and is there anything better than Quorum that's worth switching to at this point?
Okay, we've got one more question, and what I want members to know is just we have really combined item D and E. The only item that we have not covered is Elizabeth Smith and Mark Dixon from the OMIG. I don't really know that it's necessary to bring them up unless a member wants to hear. They're basically going to talk about what we've already discussed, which is identifying people who are dead and getting premiums, which again I think we've hammered to death. So unless there's just a compelling need to do that, I know they'd be disappointed not to get it done. We'll consider that done. Terry, Senator Rice, you're recognized.
Thank you, Mr. Chair, and I thought we might be combining this up towards the end. I didn't wait any longer. We'll have Mr. Stephen there. John, today and other days, you and your staff have commented just a minute ago about the cooperation that you received. You've been pleased with it and all. I'm asking you directly. Been 2 months this week since legislative council approved your contract. You've given us a good amount of information over the different meetings and all that gives us a lot to review and chew on. I want to know from you, is there any, in the context that we, through the chairs, hopefully okayed it. We had some discussion yesterday about some of these other committees or whatever taking up your time. Are you being able to focus on what you need to? And I'm asking you directly, have you been either urged or asked or implied that you need to be doing other areas other than what you feel, and I know you're working with the task force, but what we asked you to do in your original contract? Are you getting to do what you need to do without being delayed, or maybe some things coming out at a different time?
Yeah, I would say 100%. We're getting full cooperation. We're exactly following our timeline in the RFP response. And I wanted everyone in the beginning to know, we're going to look very methodically at the entire Medicaid program. We're going to try to identify everything we can that could bring value to the taxpayers and to you and give you options. And then we're going to start putting together some ideas on solutions. So we have to analyze the data. So yes, the answer to your question, absolutely. But the issue is there's a lot of people that want to have us meet with them. There's a lot of time that it takes to meet, to do, a really good, thorough evaluation. I want the task force to know we want to do that. Senator Hendren and Representative Collins have been great, and have said if there's issues that waste your time, let us know. If there's a place you need to be, you think you should go, just let us know, and we want to be there to make sure you get what you need. So at the end of the day, it's been not just the support of the department, but it's been great support by the legislature. We're coming to a point, and not everyone's going to be happy. I'm just being honest here. And I'm starting to feel that way because we're starting to talk about some things that are going to bother the people that are sitting behind us. I'm just being honest. And you're the policymakers. You're going to be making the decisions. I said from day one, we're going to give you options, and I feel very confident because we're getting the information we need to get you what you're going to need to make the very difficult decisions here. So yes, to answer your question, I know it's a long answer. If it comes a point in time that I feel we're in a situation where we're not getting the value and not being able to focus, I would let this committee know. And I think we have a great relationship with BLR and notify them a number of times if there's any issue at all. The reason, and I want you to know, the reason we bring some of these issues up, and we're not trying to bring these issues to your attention on the issues we're discussing here with the system, because the deceased issue we're talking about, and the incarceration issue, and these other issues, in the scheme of things, yeah, they may be like this compared to what you really need to look at. But the issue is integrity. The issue is making sure that the entire system works for you and the taxpayers that you serve and the constituents. And that's where we are. I feel strongly that we're in the right position.
Thank you, Mr. Chair.
Thanks, Senator Rice, and I appreciate the question because I think it is important that the entire task force feel comfortable that our consultants are getting the support and from both the state agencies and from this task force to do what they need to do. And let me just also say that This is very similar to the process that we went through with some reform efforts on state and teachers' insurance in this regard. Before we had the special session and passed several bills that required statutory change, and Bob Alexander testified earlier today, we made a lot of changes in process and procedure and regulations that we could do without legislative action. And what we are hearing here today is exactly the same thing. DHS has been made aware of a problem that, OMIG identified dead people and we're paying premiums. Now they're figuring out a way to fix it. And we're going to, as we move through this, that's exactly what we want to see happen. We don't want to wait until our final report at the end of this year and our final report at the end of next year to start saving money. So, and improve efficiency and streamline our processes and make sure we can get things accurate. So I appreciate the work that you all are already doing to fix these problems as they're identified. And again, a lot of this stuff you guys can do internally. We identify it, you all fix it, we monitor to make sure that the fix is working, and we press on. So I think that means we're making progress, and sometimes progress is painful, but nevertheless it's progress. So again, I appreciate the effort, but we will continue to ask. As I've also said, we've combined item D and E, and I don't, again, think unless somebody really wants to hear from the OMIG talk about what we've already talked about, we're going to go ahead and consider those items discussed. What I do want to do those, since Martha's down there now, and it is an item that we have an obligation to consider since it was kind of sent back to us. You all recall the contract we asked Martha to work with and give us some comments on. So you go ahead and go through the recommendations, which I think are in our report that we got.
Are you referring to the EEF project or the McKinsey contract?
Well, let's do both.
Okay. All right. Just very quickly, we didn't want to rehash history again on the EEF project, but wanted to just give you a pulse on what we consider to be some of the risks that are actively being managed right now. We talked briefly about the IBM product. It is at the foundation of this project, and so that's why the question is on the table as to, is it the viable long-term answer? Because before you continue to invest in it, you need to know, is IBM willing to invest in it? Are they a partner with you on this journey? And is that the best answer out there? And so between the Gartner report and the conversations that the agencies have with IBM, we feel like IBM has recommitted that they're not going to walk away from this, which is an important risk that is being managed. A PMO is now in place. As of the 1st of this month, the PMO has been staffed. All the positions except one have been staffed, and they are beginning to produce the things that you would expect a PMO to produce, such as an integrated Gantt chart with a schedule and dependencies. And so as of tomorrow, the first draft of that will be given to the agency, so we'll be able to see that very shortly. And then by mid-August, it'll be more robust with all of the subtleties and dimensions that you would expect to be managed there. A revised advanced planning document has been filed with CMS with forecast through the rest of the fiscal year, the federal fiscal year. So once again, you're managing the risk to make sure you continue to get federal support in coming up with their share of the money. Procurement is moving forward with the traditional Medicaid option. And so requirements have been written, and there are people beginning to start working on an RFP. One of the risks that we wanted to highlight back to this task force is the fact that you've got a gap. Procurement takes a long time. So procurement will take about a year. If you start now, you're not going to have a new contract in place with whoever it is that you select for about a year. You've got current contracts that run for about another 6 months. So that gives you a 6-month gap and creates a, well, what do I do? Do I simply do an extension and keep all of my existing players in place for another 6 months, or do I do something else? And one of the things that we notice here is we seem to have fewer choices than some other states do in what to do in that situation. That there seem to be some other procurement mechanisms in other states where you would have had a short list of kind of pre-qualified vendors that you weren't sure what you might need them for, but some were technology vendors, some were management consulting vendors, some whatever skill set you want. but that you would have had a short list where you'd have another option to buy off of pre-negotiated rates from pre-qualified vendors, and you wouldn't be stuck with the default of, all right, I've got to just do a 6-month extension. So we're looking to see, is there any option here that would allow you to have any greater choices? But that does seem like something to think about, because it applies not just to this situation, but to other future situations of when you find yourself in that dilemma, I need a fast answer, I need to make sure that my vendor feels the pressure that I can choose somebody else, I don't have to default to just them. How do you do that?
Are you working with the department to develop recommendations about how we put in place systems? And I guess the other thing I would ask you is it going to require a different philosophy with regard to staffing and in the procurement process? What I mean by that is we're going to have to hire more higher paid people, or we keep getting burned off procurement.
Well, I don't know that I can comment on the people just yet. We will be glad to do that as part of our report. I think in terms of the overall contracting, one of the things that we'll talk about later is what we're seeing as the consistent pattern in the contracts. Where are the strengths and where are the weaknesses? So if I can comment now or wait until we get to that part of the agenda.
Let's just go ahead, as I said, since you're the spokesperson on both of these items, the McKinsey contract and this one, you want to go ahead and discuss that another time?
Yeah, so we looked at the top 25 contracts, and some of the things, we listed the contracts here for your specific review, but we came up with a number of observations. And what we're looking at there's some great examples of a lot of teeth on these contracts. For example, the Optum contract for the decision support system. It has a liquidated damage of $500 per milestone per day the work is late. And if you have what's known as a severity
Okay,
warning.
can you hang on just 1 second? This handout that you have here, is that in report 1 or in the appendix, or where is that?
It's in the appendix and it's in the PowerPoint that you have today.
Okay, so if y'all want to find it in the appendix part of the report, and also should be a handout. Thank you.
So we looked at these. You've got some great examples of where you've done things well to really hold a vendor's feet to the fire, to make sure that that vendor is very, very motivated to do whatever it is that you want him to do. Be on schedule, deliver quality work, deliver work with zero defects, whatever it was that was important in that situation, you've got some real teeth in that. So we found some great examples there. There was another contract, the health management systems contract, where the vendor was held responsible for delivering everything they promised in their proposal, which is another best practice example there, that whatever they sold you on is indeed what they had to come through and deliver. However, most of the contracts were not that specific, and there wasn't that much meat around what the consequences are if the vendor fails to perform. Most of the performance indicators, and all the contracts do have performance indicators, but they read more like a scope of what the vendor is doing than a quantitative statement of to what quality standards does that work have to be done in order to meet expectations and receive the money that they're going to be paid. So there certainly are some opportunities for improvement there. We also wanted to comment on the contracting vehicles that were used. So
We'll move on to that. We got a question now. Representative Murdoch, your reference.
Just a quick question for clarity. Just a quick question for clarity. When I see contractors' names, individual names, just each one of these valued contracts is an individual contract.
Correct.
So if I see a name 6, 7 times, each one of these are individual contracts.
Correct. So this is not summed up how much money is the agency spending with this particular vendor across multiple contracts. That it isn't tracked that way.
It's just each individual, each one is separate.
With the idea being that in most cases you're going out for a competitive bid, And if the vendor legitimately wins 3 contracts because they really are the best, then that's still a good thing to do.
And that's gonna be my next question. Most of these are competitive bid contracts.
Well, I'll tell you which ones are and are not.
Thank
So there are 4 sole source. If you're looking at your list, it's number 2, number 13, number 20, and number 21, which are the ones that were sole source contracts. There are 3 that are intergovernmental agencies, which don't require a competitive process. If you're using another government agency to do the work, you don't have to competitively bid for that. Those are number 6, number 17, number 24, which you probably recognize by the names. And then all of the rest, that leaves 18 that were competitively bid. So the vast majority were competitively bid.
Thank you.
And I will just highlight some of the challenges. There's not a lot of infrastructure to support your procurement process in terms of centralized databases and easy tracking of information. There's not a lot of support for tracking of the money that's paid to these vendors. It's a manual process to match the invoices against the funding sources and against the amount that was budgeted for that vendor in a particular year. So it's pretty manually intensive to do this. And that is one of the barriers. If you go to a lot more refined deliverables and a lot more of these contracts, we are increasing the workload of how much work it's going to take to manage and follow the financial trail there. But given the amount of money, obviously that's something that has to be done in an extremely accurate fashion. Do you want to jump to the McKinsey contract?
Yes, please.
Okay. So we were asked to take a look at the McKinsey contract. In the last briefing, we talked about using a short period of time to try to take and put some more specific deliverables in that contract. We have been working with the agency who has been working with McKinsey, and we've done exactly that. McKinsey outlined a framework of what they believe the work would entail. That has turned into a series of 53 separate deliverables. We have gone back and forth on a little bit of wording change, which the Stephen Group is quite comfortable with the wording change that McKinsey has proposed on what happens if an episode design is discontinued. We've clarified what happens if McKinsey is going to get authorization before they start work on an episode, and then what happens if that work is canceled midstream. We've suggested that you use your standard cancellation clause in your contract as the role model and just apply that at a lower level of detail. So that seems to be agreeable. And then there's some final discussion going on. There was one deliverable that was still $1.5 million, which we asked McKinsey if they couldn't take that and make it a bit more granular. That one kind of stuck out as odd, given some of the others are anywhere from $60,000 each to $400,000 each. The $1.5 million one was just kind of out of sync, and McKinsey's still looking at is there a way to chunk that up into some smaller deliverables.
So Martha, if I was to just summarize the situation on this contract and as a refresher for those, this was referred to this committee to review. We reviewed and recommended that the contract be approved, but that separately, you and the Stephen Group work with the agency to primarily focus on deliverables and basically be our eyes and ears to make sure that the contract is in a place where we can feel good about the decision we made to go ahead and fund it. It sounds like with the deliverables and the interaction you had, that this item we can now put a checkbox on it and move on to our other things, correct?
Yes.
Senator Irving, you're recognized for a question.
Thank you, and I appreciate the work you did on that. That was my request, and I very much appreciate that. I have a lot of concerns about deliverables and money we paid out with previous contracts to this company where that wasn't me clearly defined. I have a question on page 31. You said, given the dollar amount of these contracts, it is surprising to see the sole source contract to HP McKinsey, Smart Consulting, and DataPath. Just wanted to follow up, why is it surprising? Why was it surprising to see that that would be so, I mean, what, I guess, elaborate. You know.
Simply because many states have in statute a dollar amount that is the maximum you can do a sole source contract. So the idea is that typically larger amounts of money are more competitively bid, and sole source is used typically from small amounts for more short-term nature contracts. Doesn't have to work that way, but that's what we see in a lot of other states.
Is that statute? Is that a statute requirement in every state?
In some states it is, in some states it's a procurement policy.
Okay, so it is both. That's interesting. Okay, thank you.
Okay, do y'all have anything else to add on those items? Martin, thank you for your work on that. That's, again, this is what we were talking about. We're making progress as we move towards the solution. All right, we're going to go to item G, the cost data from private option providers. And if there's not an objection, I'd like to have all the folks that are on item G come on down to so we can avoid back and forth. So we've got Don from DHS and John from John, you might want to come back. Sam from Blue Cross, John Ryan from Ambetter, and Liz Hunter from Fall Choice. We've got all the experts in Arkansas right here in one place. Let me just say this item is a result of some requests by the chairs to try to get a better grip. Early on in the task force, we wanted to try to figure out, as we were looking at the Medicaid expansion population, where are most of the dollars going. And obviously for the state, most of them are going to insurance premiums, so we need to be more specific, get more data, and try to ask the insurance companies to help us. And I appreciate your all's willingness to do that, to help us to try to understand how this population, how their healthcare needs are showing as far as cost to you all. So I guess we'll just start here with the item, go down the list here, and I'm sure there'll be some questions and comments as we go through. But Don, do you want to open it up there? Hey, Senator King and Senator Ingram, you guys kind of take it out back there.
We're done.
All right.
I got it straightened out.
All right. We appreciate that.
Good afternoon, Dawn Seeley, Director of Division Medical Services. I know we've got quite a panel here, so wasn't planning on making a full presentation, but certainly happy to answer any questions that you may be able to do so.
Well, let me just ask, how this, was the data given to DHS at all, or are we just going to hear from each of you all individually, or how have we got this together?
The data, and I'll certainly defer to John Stevens as well, but the data has actually gone through DLR, and then that data was then accessed to the Stevens Group. So we've not actually seen, in terms of for DHS, we've not actually seen the data. But like I said, we're here, because we're on the agenda, and obviously happy to answer any questions.
And I guess, John, are you all using this data now as you study the program and determine where we are?
Yes, and we've started analyzing. And
Okay.
they've been very cooperative. There are some issues in terms of identifying ID numbers and some just glitches we call minor data cleansing issues right now, and if we have other problems, we'll let you know, but it's been really very productive discussion.
And again, I know it's always sensitive when the government asks private industry or private sector to start providing information, so I appreciate y'all's willingness to do that. So I guess let's just go in order here for, so Sam, how do you say that last name?
Give it a shot.
Borda, all right, I'm going to get Borda Strassi.
Very good.
From Blue Cross.
Half my family pronounces it that way. Border Strasse. I'm Vice President, Chief Actuary, and I brought that to Arkansas Blue Cross Blue Shield, and brought on Matt Flora. Introduce yourself.
I'm the Director of Medical Informatics, who is responsible for most of the reporting that comes out of our enterprise data warehouse within the Blue Cross system.
So I characterize my role in the high-level questions you may have about cost of the program in 2014, and if we have any deep dive questions, now
Okay. Well, I guess I'll start. Tell me how this, how the cost history for this population compares with your private sector experience?
That's that, you've done some studies on that particular part, as far as comparing our other population besides the exchange.
Right, we've done comparisons to kind of our traditional individual policies under the kind of pre-ACA world of kind of extended door grandfather policies. And we compared them to the fully insured group business because we represented a different benefit mix than was represented in the private option. And Sam can kind of speak to some of the differences that they've accounted for from the actuarial perspective. What we're seeing as general experience is there is a higher cost per member within the private option population. A lot of that is related to higher utilization within emergency room services and inpatient, outpatient facility services, as well as professionals, so kind of across.
And when you say higher, higher than what? Typical commercial policies in the private sector?
Right. When we compare it to our fully insured group business, the emergency room utilization is as much as 5 times higher per capita. The inpatient admissions are around double what you would see from our fully insured business. And primary care utilization, you see slightly fewer members overall as a percentage going to primary care physicians. However, those that do go with higher frequency.
So it is significantly different in utilization of medical services than your traditional commercial pay population.
Within the initial year of experience, we've had to evaluate that as well.
And how I can sort of fit that in with the exchange overall. Being an actuary and sort of in charge of the pricing of the product going into 2014, we knew it was going to be likely that was going to be the case, not only for the private option, but also the other exchange, the marketplace exchange, the federal exchange, participants in the exchange. One thing primarily is you knew that a lot of the high cost pools that were in existence, you knew that those were probably the folks that would fall into the exchange. Plus you of course don't have underwriting any longer. And then also we had some studies that showed that that was probably going to be what's happened, and that's generally the case, is what it's turned out to be in 2014.
And your statement that the ER use is 5 times, did you say 5 times what you see in similar populations?
I wouldn't necessarily consider it to be a similar population, just more of what the traditional fully insured employer business is. It'll have a different benefit makeup, which can impact utilization.
Okay. Go ahead, push your button there.
And you have a decrease in primary care costs, or not decrease, but a lower amount compared to the other.
I wouldn't necessarily say it's significantly lower. Be able to make that statement at this point in time with only a year and partial year enrollment to compare to. What we do see is those who have visited a primary care physician go with higher frequency than those that go to a primary care physician within our traditional fully insured business.
I guess what I'm going to get at, I just want to ask you, so more, just people are still going to emergency room care except for the primary care?
Yes, sir.
Thank you.
Okay. I guess, and I know that this may be a question that you don't want to answer, and feel free to say that if you don't. Do you feel like the profitability on this population, based on the way that you price the plans, is similar or less or more than what you see in the private pay market?
It's similar, and I'd also like to add, and we have seen the margin in the 2014 calendar year, but it's not excessive, and I think we can point to that we don't expect to pay rebates on any of our business for 2014, and we also will not be making payments for the risk corridor program as part of the exchange.
Okay. And unlike, and I guess guess what I would ask you all is, when you all price your plan, you basically do an actuarial study of how we think this population, what healthcare services they're going to utilize. And then you price your plan, and the state agrees or disagrees, and we move forward. But is there any effort at all to try to change behavior in this model about delivering healthcare services to try to drive that ER use down?
Certainly. One thing in particular, and that's where the private option, you have to remember, is part of the marketplace. It's part of our commercial population as we see it. And they are part of any programs that we try to put in place for the commercial market. And including, they are very much part of our initiative to get people to sign up for the PCP. They're included in all our
PCP being
primary care physician. Designated primary care physician, that's such an important part of the healthcare delivery system. And the entry point is what we want it to be instead of ER. So that's one case in point. We also include them in all our care coordination efforts and case management efforts, just like any other member that we're on the risk for. And also we've incorporated them into our financial arrangements with our providers. Shared savings provides more volume, it gets more attention to provider partners by using the membership of the private option.
Now, obviously running a company as massive as what you do and the responsibility you have, I know you're some smart guys with some good business sense. So if I were to ask you, if we had to find a way to bring savings out of the current model, as you can imagine, the fact, the looming idea that if we continued this, we would have to come up with a 10% match, which would be significant budget impacts. What would you suggest as things for the state to consider? You guys do this for a living. How can we make this a more affordable option for the taxpayer?
Well, I'd have to say that, frankly, I assume that we would be doing no matter what the private option turns out to be, whether you go with a managed Medicaid route or you go with the commercial population the way they implement. All of the management, or all of the folks involved with the financing and taking care of these people will want to go with a high quality, cost effective, efficient way of managing these people. So I'd have to say they all have the same goals in mind, and the specifics might be different. In our experience, it takes a while to bring the cost savings out. The cooperation, the most important people to get involved in that are, of course, the providers, and it takes a while to get those kind of things working. And we're actively working and have been working night and day to provide that to this population and all our population. So I think many of the techniques that I just talked about, care coordination, having a PCP, trying to get financial arrangements in such a way that the providers are incented to help with fee-for-value type programs and policy for fee-for-value.
All right. Do any of you from Blue Cross have anything else you want to add before we go on to it?
I just want to add that, when you said cost, I expected that the steering group is able to pull their stuff together. That's when you'll have a lot more specific cost there.
Okay. And you have provided them the data, and they're going to be getting that together. And if we have questions about it, you can talk to them, or we need to come back and ask them again. We've got one more question here before we go on to, I guess the next one is Ambler, but we've got a couple. Senator King.
Mr. Chairman. We're talking about these people that don't qualify. It's been estimated by Nurse Seeley that it could be 20 or 40,000 people. Just testify to that. If you take those people out, would that affect the price per month?
Well, it depends. Those are the kind of things that as an actuary you don't like to hear, are sudden differences and changes from what you knew when you priced the product. And so we knew about where we were going to have as far as enrollment. We wondered about the incoming determination that we didn't have any hard facts to go with, but we had to come up with a particular price for the next year, given certain assumptions. That's the first point. It depends on how it happens, who leaves. You know, it's people that lost their coverage. You do wonder if the people that are in the hospital or getting coverage, they might be a little more interested in making sure they keep the coverage. But it doesn't necessarily sound that's the way it might have happened this time. So depends on if those people were the folks that weren't using it versus those that were. And so right now I have no information to know if that would hurt or help the commissioner.
I have one other question, but I don't know that it really deals with this issue. Are you guys going to be around after the meeting? Okay, probably better to ask. I think.
Member Rice.
Okay, this was a question somebody asked that, and what are you doing as the insurance company to teach people that are covered to get to a primary care doctor? The thing I know in my personal insurance, which is company's Blue Cross, I received something the other day for the first time that I know of, and my wife and I, we haven't had a visit recorded in some time.
All right, well, I was understood.
We are actively engaged in a campaign, beginning with the exchange and private option business to inform them about the importance of the relationship with the primary care physician. We do review their claims history to determine if they've had any visits, and if they've had, we encourage them to continue to visit that physician. If they've not, we've got ways for them to contact our customer service via the internet or telephone, or even return a letter to indicate who their PCP would be should they need to receive services, to remind them to start establishing that relationship. And in the case that we do not receive a response from that campaign, we attempt to reach out again with a recommendation of a local physician within their area to try to help establish that connection. I think we're nearing the end of that campaign with a particular block of business affiliated with the exchange and private option, and we plan to extend it to all of our commercial business.
And, you know, as we touched on here, the difference between areas of Arkansas and even from a rural area, even though my district has some area that has pretty good access to doctors. In the rural area, we don't, so it's a challenge at times, but appreciate the efforts. Thank you, Mr. Chairman.
Secretary Bledsoe.
Thank you, Mr. Chairman. Pardon me if this has already been asked, but I stepped out for a few minutes and I'm not sure. But when we talk about those that are not eligible that were on the private option, those people receive services from providers during that time. And it's my understanding that there may be an effort to recoup those expenses that were paid from those providers. But they, in good faith, took care of those people. What do you say we possibly should?
Well, that's a policy that I probably should touch on, but I think it's, generally, I don't think that's very many folks. I think most of the people we're talking about are going to be canceled prospectively, so that would not happen. So it's just a few folks that I don't think it's a big part of it.
Well, probably to that provider, that might be a big deal. So you don't have anything concrete that you can say at this time? Okay. All right, thank you very much.
Okay, Representative Murdoch, you recognize.
Thank you, Chairman. So overall, as you sit here and see what we as a task force can balance with several different factors and variables. U.S., you guys make money, you're in this for profit, and which is fine and good. But you see kind of what we battle with, and we want to not hinder you, but we want to try to get to some acceptable and reasonable state with all of this that we're battling here. Do you feel a sense of responsibility to this process that we're trying to make better? You know, can we depend upon you, or do you think we should be able to look to you for part of the integrity that I hear about that needs to be a part of this process from the state's standpoint, definitely, but even from you? Can we discuss that a little bit, just to know what you think?
First of all, by all means, if you have asked, and you have, and more forthcoming with all what you can do to help. And it's, we are an Arkansas-based company. We feel that very much so. We're all about Arkansas and the health of Arkansas, Arkansans. And for sure, I can't probably say it strong enough, but we're here to help.
Right, so when, obviously, when you're in a reclamation mode or improvement mode, you, and sometimes on the other side of it, you may see opportunity, you know, that escalates your bottom line. But, you know, so we're asking, what I'm asking to, on behalf of people I represent, is that, you know, we need help with that. And Mr. Stevens, as I look to you, in your overall view, as you come up with a final report, will you be engaging with them and challenging them and giving us ideas, advice on how we can possibly ask them to help us and be a part of the process? Because so many times, even in my business, many times I can see errors in the ways of those that I sometimes won't work for. And sometimes they listen, sometimes they don't listen to me when I try to give them ideas on how to cut costs and how to do things in a more efficient manner. So it's not your fault if we don't listen, but I do feel some responsibility to the owner when I'm working for them to at least say things that I think will help them.
Well, we have tried, or we have been fully engaged to help and give advice, or at least tell people what we see all along through the process.
Thank you. Appreciate it.
Okay, thank you all. Unless you all have something to add, you can just sit there for a minute because there may be another question come up. But let's go ahead and go to Ambetter. John Ryan. I guess what I'd ask you first, anything you'd like to add that you've seen different than what you've heard here and would like to comment on?
Sure, Senator. John Ryan for the record, Arkansas Health and Wellness. I think probably the only thing that I would say that's materially different than what Sam talked about was, I think his comparative was to his in terms of cost and utilization, and what Blue Cross is seeing is that they've got, and this is no secret, they've got a large commercial base. To compare that to the state of Arkansas, where it's we don't. So any comparative that I might give you would be towards the expectations we had in pricing the product, kind of an unknown commodity, if you will, in early 2013. So we essentially don't have any other commercial off exchange or FFM business that was a comparative for us for me to be able to speak to today. So any comparative is just versus the expectations we had. And so to that end, I think what we have seen in 2014 is some of the same themes that Blue Cross and perhaps Qualchoice have seen as well, in that utilization, at least for us, in the ER was higher than what we would have liked to have seen. The primary care utilization was a little bit lower than what we would like to have seen. I think that those are probably intersecting now, and we're very hopeful in doing some of the same blocking and tackling things that Blue Cross is doing, and trying to shift that setting of care to the PCP from away from the ER. So I think we're seeing that convergence with the implementation of primary care medical home strategy that we've just deployed in May. So we hope to see some of that shift. As a whole, compared to where we priced the product in 2014, we've actually seen better utilization than what we expected. So I don't know that that's a function that we did something better or worse than Blue Cross did. It's probably a function of where our premium was set to begin with in 2014. Not having the experience of the Arkansas marketplace in a broad footprint like others might have, and then never having worked with a population that's quite like this in Arkansas. There's probably more conservatism baked into where we were in 2014.
Would you say that you've seen similar trends as far as much higher ER utilization than traditional?
Yes, we're primarily in the Medicaid space, so comparing to other states, which is not necessarily apples to apples, for a Medicaid population, utilization is lower than that, but it's higher than what we would have perhaps expected.
And I think the same question Senator King asked in Blue Cross folks, are you concerned in just the potential of lots of cancellations due to eligibility verification and redetermination concern you?
Yes, it does. We're studying that right now. Our actuaries are looking at it this week to see what kind of impact it might have and what steps we might need to take to mitigate that. So Sam hit it right on the head. Actuaries don't like to hear things like that. They like things steady and down the middle and predictable, and that's a little bit of an unpredictability that's factored into the mix now.
Well, let's suppose that, again, I want to know how the process works here. If 6 months down the road, we have had to go through this process and redeterminations have eliminated thousands of folks, and you see that unfortunately they were maybe perhaps many of the ones that were healthy and the ones that were sick certainly re-verified. Would it be possible under the agreements that you have with the state to come back and ask for a price increase, or how would that process work?
Not to my knowledge, in the middle of the plan year, if there was any action to be taken, it would probably be now, prospectively for 2016.
So you do have the opportunity, so it would be for the following year, which you have until like March or something, when you have to submit the prices for the next?
That would be, yeah, roughly that time frame. That would be for the 2017 plan year. If there were any action to possibly be taken right now for 2016, it'd have to be in a very short window coming up.
But you don't anticipate that yet?
We're talking about it right now.
Okay. All right, we've got a couple on the list here. Senator Irvin, you recognize him?
Yeah, and I appreciate that, because I've asked that question to Mr. Stevens about eligibility and fluctuation and coming on and off, and continuing the conversation there with Senator Hendrick, but also, are your administrative costs of people coming on, people going off, is that built into your actuarially reports on setting your premiums?
Sure. I mean, you have an expected service utilization with the admin piece of the business, and anytime there's any volatility of people turning in and out of programs.
It's designed to eliminate churn, but eligibility verification and redetermination could actually increase churn.
Right. I mean, that's what we know today. That's an entirely possibility.
And one last question, and for everybody, are the communication, and a little bit follow up with Senator Bledsoe's line of questioning, but communication on the recoupment based on non-determination, non-eligibility from providers that provided service. Are you all doing that? Or is that policy across the board? And if so, and are then the premiums that were given to you by the state recouped from the state, from you?
Well, I think as Sam said, as long as the termination effectiveness is on a prospective basis, that really doesn't come into play. So as long as we all know as issuers that an individual or a group of individuals is affected or terminated on a prospective basis, then we have the ability to impact that in our system and hopefully prevent any type of recoupment we're talking about. Because providers can hit all of our portals and check eligibility, et cetera, and know that an individual that presents in their office is not eligible with that particular claim.
Okay.
And I don't want to speak for Michael saying, but that's how I'm looking at it.
Okay, so, but there is some retroactive recoupment that might be taking place.
I think it could be in certain circumstances, but I don't see it.
That's for Blue Cross, yeah. Okay. And then the Baltimore credit. Thank you.
Representative Farrar.
Thank you. What is your market share right now in this product?
Right around 20%.
20%. At what level would that be detrimental to your company if we hit a certain number of people?
As I mentioned, we're looking at that right now, but I mean, because it is 20, if you have a larger pool with greater stability, then you have greater tolerance to absorb more of a swing, positively or negatively. So
Well, I guess that's why you got 80% sitting beside you, or 75% beside you, and your they can absorb that, and if you go away, they absorb you,
Yeah.
then we have a single parent system.
I hope Sam doesn't absorb it, but.
But if this redetermination knocks off 20,000 of your people, are
Right. The margin of error,
you can't be here.
the margin of error is thinner for us.
Right.
It's a standalone entity in the state.
But then you have to raise premium costs, and the premium cost goes higher than your neighbor right next door to you, then everybody goes to Blue Cross.
I mean, I think that's a fair hypothesis.
So how do we fix that? Because we need competition to save our insurance. We need, actually, we need 7 insurance companies saying, sorry guys, so we do. How do we fix it?
Well, I mean, in terms of groups of individuals that leave the program that might leave our plan in mass, even if it is a prospective basis, I think you all have heard today about some of the challenges of the redetermination process. I mean, I would advocate slowing that down and doing it, maybe more correctly than quickly. That would be one way to maybe assure that we could do some of that, keep things more stable.
How do your company capture the market share and keep the product?
How do we capture more market share? I mean, I think that's up to us to demonstrate our ability to control utilization, to provide quality service, and then that's going to be reflected in premiums, which are going to be competitive.
Okay, that's all I've got right now on the list. We've got one more. We've got a couple folks here from Qual Choice, Michael Stock, and Ms. Hubbard. So if you guys identify, tell us your position, you're recognized. And again, same sort of questions. Any observations you have, good, bad, indifferent, and then we'll open it up for questions.
My name is Mike Stock. I'm the president of Qual Choice here in Arkansas. Liz Hubbard is in charge of our, what we call corporate responsibility, which is our compliance area. I guess the things that I would say, to echo what Sam and John have talked about, first, make sure that the task force understands that the population that we have to talk about with you right now is a little bit different, because at the time that the private option was rolling out and we were first participating in that program, we were going through an acquisition where our company was being acquired by Catholic Health Initiatives. And so as a result of that acquisition and that transaction pending with the state, we had asked the state to hold our membership down until that transaction completed. So for about the first 6 months of the first year of the program, we had very little membership that came to us in the private option, just a couple thousand people. And then after beyond that 69-month window, much more membership started coming in. So a lot of our membership, we're up to about a 20% penetration in total private option now because of the way the assignments work in the state. But most of our membership has come on in the last 69 months as opposed to in the first 69 months of the program. So our cost experience is based on a very small population, and largest portion of the population that we have is much later occurred. A couple things that I would say we've seen in terms of the cost patterns that Sam and John didn't talk about. One is that the membership is, as we've identified, seems to have a lot more comorbidities than we see in the rest of our commercial population. And by that I mean there's a much higher percentage of the total enrollees that have multiple disease states going on as opposed to dealing with a single disease issue that they're facing. That could be part of the lifestyle that these people lead based upon their social economic position. Don't know exactly. We've also seen, though, that while our overall medical spend is higher than what we would experience in the general commercial population that we take care of in the state, the spend on pharmaceuticals is lower, and the amount of generic utilization is higher in this population than we see in our general commercial population. Maybe that's because the commercial population pays attention to all those TV commercials that the pharmaceutical companies run, and when they go into the doctor's office, they demand those new brand drugs, which helps to drive things up.
Can you, do you have any, that's an interesting fact, any idea about why while the cost is higher and comorbidity is higher, that the prescription utilization is lower?
Well, I think part of it probably is because, like the other two carriers, we've seen lower participation and lower utilization at the primary care level, and most of your prescriptions come from primary care physicians because they're the ones that are doing the physicals first identifying that you have diabetes or blood pressure, issues or things like that, and trying to get you on prescriptions to lower those. So it will try to follow various federal guidelines in terms of how we get place drugs on the pharmacy, but we try to put as many